in the body. They also lead to cardiovascular or non-communicable diseases. So oxidative stress, antioxidant capacity, and low-grade inflammation have been reported to potentially play a role in many non-communicable diseases, including mental disorder. We have mitochondrial dysfunction. Mitochondrial dysfunction simply means that the mitochondria is not functioning properly. And the mitochondria is where energy is produced. And because energy is produced in that in the mitochondria, it's very sensitive to anything that will affect energy production. So oxidative phosphorylation is the major ATP producing pathway, providing about 95% of the energy needed in the body, and this takes place in the mitochondria. And then tissues like brain with high energy need contain a lot of mitochondria and are sensitive to deficits of aerobic metabolism. The mitochondria also contains synaptic transmission, calcium ion signaling, production of action potentials, and ion homeostasis. It contains an extensive antioxidant defense network and multiple electron carriers that can produce reactive oxygen species, making its dysfunction a source of oxidative stress on its own. So it's also shown to have effects on cognition, brain fog, and fatigue. So, and in the nutritionally, niacin and riboflavin are cofactors in ATP production. And then heme ion deficiency causes mitochondrial deficiency and oxidative stress, while the production of iron depends on nutrients like vitamin B6, zinc, and copper. So you see, there's a lot of interrelationship in nutrients. So all these things is taking us to the fact that adequate diet that contains all the essential nutrients is really what will help situations. So things like polyphenols, are known to improve mitochondrial functions. So we have the brain-gut microbiomes or microbiota gut-brain axis. This microbiomes is the term we use to refer to the trillions of microorganisms that are found in our intestinal tract. And the microorganisms also help to induce healthy gut. And their diversity and their functionality is very essential. So if you have a lot of them, particularly the beneficial ones, Bifidobacillus and the rest, then it's an indication of having a healthy gut. So it has been shown that their diversity and balance, are important for general health, not just for those with metabolic disorders or mental health. So gut microbiome interact with the brain in a bidirectional way using neural, inflammatory, and hormonal pathways, which we will see in some of the diagrams that we have. Let me see. Okay, this is one of the Bacter gut brain axis. Like I said, you have a lot of secretions. The pathway it does this through the immune pathway, neuroendocrine systems, and the enteric nervous system, and circulatory system, and the vagus nerve. And this pathway, when they are stimulated, you have a lot of secretions like peptides, gut hormones, microbiota derived products, and microbiota derived metabolites. All of them send signal to the gut brain axis, and this influences the neurodevelopmental and psychiatric diseases that have been listed there, like autism, depression, anxiety, and so on, and also neurodegenerative diseases, multiple sclerosis, Parkinson's disease, brain tumor, and the rest. So we also have visceral fats. Adipose tissue fats are active in the secretion of pro-inflammatory cytokines, and other substances which I've mentioned before. They disrupt the normal function of the brain neural circuit, leading to mood disorder and cognitive defects. This is why individuals with metabolic syndromes are at increased risk of developing depression, anxiety, and other mood disorders. Leptin has been found to play a role in obesity, and plasma leptin levels are found to be predictive of the potential for cardiovascular pathology. So you have neuroplasticity and neurogenesis. And neuroplasticity refers to the changes in the structural property and function of neurons in the brain and the synapses they form, while neurogenesis is the formation of new neurons and ganglia cells which occur throughout life in certain regions of the brain, which is reported to be associated with learning, memory, and mood regulation, especially the hippocampus. So brain-derived factors mediate hippocampal neurogenesis. Positive relationships have been reported between omega fatty acid, vitamin A, and intake and BDNF levels, while diets rich in saturated fats have been associated with the low BDNF, low neural plasticity, and poor cognition ability. This is again a diagram showing some of the relationships that we have talked about, but here is bringing a lot of factors, even physical activity, again starting from the prenatal stage. Maternal and neonatal adverse milieu, can have adverse effects on adiposity, BMI of the child. So if a child, that is born with large BMI, already the body composition is already altered. There's excessive fat, excessive subcutaneous and visceral fat, liver, and low muscle mass. Also, imbalanced nutrition, which is at the other end. Increase energy and fat intake, reduce fiber, omega-3 fatty acid intake, high intake of trans fatty acid, low intake of fruits and vegetables can also disrupt the body composition and increase the fatty acid levels. And all these fatty acid levels are also going to increase inflammatory cytokines production. It will increase free fatty acid level in the system, and all these free fatty acids, all of them will also lead to insulin resistance and metabolic syndrome, and then type 2 diabetes, coronary heart disease, and so on and so forth. So you can see that there's a lot of nutritional components in all these mechanisms. So intervention strategies, that is the role of nutrition. A healthy dietary pattern can affect mental health and well-being through anti-inflammatory, antioxidant, neurogenesis, microbiome, and immune-modifying mechanisms, and epigenetic modifications. Adopting a healthy lifestyle, including regular exercise, stress management techniques, can significantly reduce the severity of metabolic syndromes to improve mental health outcomes. Diet is the modifiable factor for depression. Hence, improvement in diet may be the most appropriate strategy. So here is the hypothesized relationship between diet, physical exercise, and mental health. We see here we have good quality diet. And when we talk of good quality diet, we are talking about diet that has healthy fat, limited fast food, fruits and vegetables, high in fiber. And then we also have physical health, and which will be mediated by, sorry, let me take it back to insulin sensitivity, less cardiovascular risk, healthy weight, and other health behaviors. And then when we talk of mental health, better mood, less stress, low risk of illness and cognitive function. These things are all interrelated, and they are mediated by the pathways that I've already mentioned. That is the hormonal, inflammatory, and neural pathways. And then also the multiple biological pathways. So some dietary patterns and specific components or nutrients have been shown to reduce mental health and improve health. So production of neurotransmitters, what I'm just trying to show you is that a lot of nutrients, a lot of components we derive from our food have been implicated in all these pathways and reactions that we are talking about. So something like production of neurotransmitters require nutrients such as a lot of amino acids, to be precise, vitamin B6, B12, folic acid, and we know that serotonin, dopamine, and non-epinephrine all are involved in the regulation of mood and appetite and cognition. So marine-derived omega-3 fatty acids can also decrease depression and anxiety. Many nutrients are involved. Many nutrients that we consume are involved in the antioxidant defense system, and also something like selenium, which we know is a cofactor in glutathione peroxidase, magnesium in superoxide dismutase, copper, vitamin A, vitamin C, just to mention a few, as well as in energy metabolism, we have copper, iron, phosphorus, magnesium, B vitamins. And zinc is also found in many enzyme systems and is associated with insulin. All these underscore the importance of a healthy, adequate, and well-balanced diet. The role of gut microbiomes cannot be overemphasized. They are involved in the production of neurotransmitters, and consumption of foods rich in dietary fiber, polyphenols, and unsaturated fatty acids promote gut microbiome taxes, which metabolize these food sources into anti-inflammatory metabolites. We know that if you eat a food that is rich in dietary fiber, because it is not digested in the intestine, they go to the large intestines and they are broken down by the microorganisms there into short-chain fatty acids. These short-chain fatty acids can even go back into circulation, or they can also be used to produce other metabolites, that can be anti-inflammatory. And we can achieve to have these microbiomes in our diets. We can consume foods that we refer to as probiotics, prebiotics, symbiotics, or psychobiotics. And when we talk of probiotics, we are talking of living organisms that, when they are consumed in adequate quantity, have beneficial effects, and helps the body to function well. And we can find these probiotics in fermented food like our fufu, apple, iru, all these are fermented food products. You can find them also in dairy products like yogurt, fermented, yogurt is a fermented product, and also pickled products. So these are very, very, because they contain beneficial microorganisms. Then the prebiotics are non-digested food components whose fermentation in the gastrointestinal tract stimulates bacterial growth or activity, or effect both, leading to the development of beneficial intestinal microflora. They can include inulin or fructooligosaccharides. They also impede the growth of pathogenic bacteria. Studies have shown that they can reduce inflammation by modifying the composition of the microbiomes. Then symbiotics are food ingredients that contain both probiotics and prebiotics. So they have a symbiotic relationship. So the two functions are performed in the by the same product. While the psychobiotics are defined as microorganisms that are probiotics, but they have shown positive effects in patients with mental disorder. So, apart from these components or nutrients that I've mentioned, we also have dietary pattern. You know, we eat food actually, but we all have dietary patterns. I don't know what dietary pattern we will call our own, but that is what we should try to find out. But there's a dietary pattern which is evidence-based. That is the Mediterranean dietary pattern. You know, it has been shown that adherence to it, you know, has a significant effect on metabolic disorders and also non-communicable diseases. So Mediterranean diets, you know, reduce inflammation in humans. This type of diet is rich in antioxidants because it has a lot of fruits and vegetables, and it has healthy fats, polyunsaturated fatty acids that is derived from from fish, you know, and then olive oils, and then it's associated with lower prevalence of and progression of metabolic syndromes as well as mental health disorders. So, you know, this one just shows the components of a Mediterranean diet. It has a lot of legumes. It has some wine, low-fat dairy, and olive oil, nuts and seeds, lots of fruits and vegetables. You know, these are things that you notice that you won't see a lot of starchy roots and tubers like we have, but you have grains, but they are also regulated or limited. So, other dietary patterns is we also have what is called the dietary approach to stop hypertension, the DASH diet. This has also improved depressive symptoms. It is related to, it's also a diet that is related to the Mediterranean diet because it has a lot of fruits and vegetables, and it's good for people, you know, hypertensive patients. And then the DASH diet is higher in fruits and vegetables and low in dairy and low in saturated fat. There's also the MIND diet, which is called the Mediterranean DASH diet intervention for neurodegenerative delay. It's another diet model that may be beneficial and impacts on mental health and well-being, due to the antioxidant and anti-inflammatory nature. These three dietary patterns are rich in fruits and vegetables. They are plant-based and contain less animal proteins, particularly red meat. They improve insulin resistance and are anti-inflammatory. Another dietary pattern is the keto diet, which is a high fat and low carbohydrate diet. It has been used for epileptic seizures in the past, and also recently some people are using it for weight loss, but there are a lot of studies and controversies surrounding the use of keto diets, but its use has also been suggested. So this is just a summary of the other one. So what is the summary of and conclusion? The summary is that metabolic disorders or metabolic syndromes and mental health disorders are a threat to public health as they reduce life expectancy and quality. Both are caused by genetic, lifestyle, biological, and environmental factors. However, nutrition sits at the intersection of metabolism, neurobiology, and inflammation, and a central modifiable factor. Because of the bidirectional relationship between metabolic disorder and mental health, managing metabolic syndromes can impact on both physical and mental well-being. Because we have already said that they are both related. But if you tackle the metabolic syndromes, you are more likely to also solve the one concerned with the mental disorders. Although nutrition can play a preventive and therapeutic role, early detection is very essential for both genetic and acquired disorders. So it's always, our health-seeking behavior should be improved, in that we'll seek for help and find out these things early, because if you find these things early then and tackle them, then we can slow the progression of these conditions. Other strategies like weight reduction programs, use of supplements, cognitive and behavioral therapy can also be useful. So as I was doing this, preparing this, I found that there is much on psychiatric nutrition research in Nigeria. And then, so research is needed to increase our understanding of how diet and nutrition-related biological mechanisms affect behavioral health disorder, for the evolution of better nutrition-based intervention to reduce the impact of these disorders on individuals, families, and society. Nutritional medicine should be the focal point of psychiatrist practice, and mental health screening should be routine in patients with metabolic disorders. Nutrition therapy should be part of mental health management using a health model that integrates dietitian, clinician, and mental health professionals or professional. Thank you for your attention.
I don't think you were clapping for me. So I did promise you that it's going to be very fascinating, and you can bear me witness that it has been just that. So at this juncture, okay, so our professor has talked about the link between yes, so she has shown the link between metabolic health and mental disorders, and she has shown that they are bidirectional. So, and has also shown that environmental factors, our lifestyle, the way we respond to stress, can trigger metabolic disorders, and can as well trigger, our mental health disorders. So what do we take home at this point? My advice is that we should try to, improve on our lifestyle. Don't say, I hear people say, I am not fat, so I will not, there's no need to do exercise. We think that exercise is for people that are fat and want to bring down their weight. No, we should, be very, we should try to be, to be intentional about exercising. Make sure that you exercise, and then our dietary, our food habit. She has talked about the Mediterranean diet, the DASH diet, those ones that are low in dietary fat. Excessively fried foods are not really good for health. A diet that includes a lot of vegetables and fruits, we should be intentional in making sure that everything that we eat is healthy. So she has stressed on adequate diet. So we must be intentional about our diet. We must be intentional about our exercise. And that will help, Even though there are stressors in the environment, these things will help to modify them. So these are modifiable things that we can do to modify these things. So please, I will give room for interaction. If you had questions, do we have some questions? That's number one. Two or three questions will be fine for our professor. So right now we have one. Okay, two. So two. 1, 2. I hope nobody will come after that. Yes. That's number one.
Thank you very much, Prof, for your presentation. My name is Dr. Baji Akbet, Department of Community Medicine. During the course of your presentation, I was so thrilled with when you were talking about probiotics. I thought about fermented fruits. But these days, we discovered that what people buy from the market as fufu is so polluted, contaminated in the sense that cassava that's supposed to be fermented and allowed to ferment naturally for 5 days. People now ferment cassava for only 1 day, or even less than that, because of what they use hypo, they use detergents, carbides, etc. to do this. Is it healthy for people to still go for that food? Talk about people don't allow fruits to mature and ripe naturally. They harvest them premature and force them to ripe. And when we eat these things, we become more unhealthy than where we were before. Please, what do you have to advise this group, this gathering? Thank you very much.
Okay, let's take the second question.
Good morning, Prof. and members of the high table. I watched carefully your good presentation, and I have a question. I visited a medical doctor who has all the knowledge of medicine, and he excused like 5 of us that he wants to take a small exercise. He went out to jog, only for him to end up there, not returning. That is to say, he died. And the people that were there, everybody was confused that this is a medical doctor that knows everything about human health. And he encourages people to jog. He went out jogging and he did not come back. What do you advise? Because this is, you said, inactivity, that is to say, if somebody does not exercise, it's a risk factor. This is somebody that exercised and he never came back. Thank you very much. That is question number 1. Question number 2. One Professor Nwachukwu of the Department of Medical Physiology in UNN, Enugu, came out with a recent discovery and findings concerning Zobo as a common name for his findings,
that it is good for people to treat hypertension or related cardiovascular sicknesses and disease with zobo when you don't mix it with anything, sugar and other additives. And I had a colleague that heard that presentation, it went viral. And a colleague went to prepare it as the man instructed, and he purged for 3 days. So what do you advise? Thank you very much.
Okay. Have you finished? Okay, thank you so much for all your interesting questions. I start with the first one that talked about the use of all sorts of chemicals to process the food that we eat. We know that these days people are trying to make quick money, to be fast about everything. So ripen banana very fast so that you can generate money from it. But the issue is, let me start with the cassava one. As much as if you can, some of these things like, we are told to go back to the farm to start producing our own foods. For the past, how many months, I don't think I have bought fufu from outside. So I make it myself. That's the only way you are sure of what you are eating. Or you have a neighbor who is preparing it. That's the only way you know that the person is doing it the right way. So it's either you do it yourself, or make sure you find somebody who is doing it the right way and not just buy anything that you see. Maybe because it's so white, the appearance, because the appearance does not, signify that it is the best quality. So my advice, if you ask me like I do, I don't just buy anything. I find it even difficult to send my words to go to the market because I don't know what they will just buy for me. But me, I have to have my eyes open and make sure I am buying what my money is worth, and I'm buying what is healthy for me to eat. So if you can produce your own fufu, for example, fine. Then you will have, escaped what is happening in the market. Then the person who talked about exercise, I know that's why I also said, in one of the recommendations, I said that I think it's good for people to do routine checks, about their hearts, the state of their heart. And even the doctors themselves. Unfortunately, the person you are talking about happens to be a doctor. But I know doctors will even when exercises are recommended, if you have your physician issue, he will tell you the type of exercise to engage in. So you don't, because your friend is doing 10 miles, you will do 10 miles. No. Do what is good for your own state. Personalized one that will suit your physiological state. So probably the doctor, I don't know whether to say he's not aware, but we are supposed to check our heart conditions. Our doctors are supposed to tell us the condition. That's why it's good to do routine checks. Find out your heart condition, because that is what will determine even the intensity and frequency of exercise you are supposed to be engaging in. And my advice is, please, let's not follow everything that people are doing. That somebody is doing something does not mean that particular thing the person is doing suits you. Even in food, we talk of personalized nutrition. Like that zobo you are talking about. I don't know whether, I wouldn't say it's the zobo. I don't know if to say that it's the zobo that, I think either he did not prepare the zobo correctly. The water, the container, there are many routes to introduce microorganisms into your food. So hygiene is very, very important. So that could be a reason why he has running stomach. Another thing could be that zobo, you see, that's why I'm talking about personalized nutrition. And you don't follow. In Nigeria, once somebody puts something in the internet, all of us jump into it. But if you try it, you should be able to, there's what we call mindful eating or even mindful drinking. this thing I am taking, is it good for me? Is it because it's good for A, it must be good for me? You know, we are all made up differently, genetically and physiologically. So you must know what is good for you, what you should take and what you shouldn't take. Like that's Zobo at times. If somebody has low blood pressure and because they say it's good, you go and drink it, it will knock down your blood pressure further. And then you start feeling funny. And then you can say that Zobo is not good. But it is just because you are not supposed to either take it the way others are taking it. So I think we should be very careful, you know, with what we do. I don't know whether I have answered. Somebody else can help me.
I'm a witness that you have answered. Please, let's put our hands together for Prof. Talking about food processing. Recently, I put my students on ripening, artificial ripening with calcium carbide. I noticed that calcium carbide is a very common agent that people use in ripening fruits. And I noticed that apart from every other thing, there was a reduction, you know, significant reduction in nutritional quality of the one that was, you know, that was ripened with calcium carbide. So I think we really need to be careful. But, you know, there was this time I went to the market myself. I saw this pawpaw, very beautiful. In fact, I just thought, I don't even know how, I don't know how that pawpaw just turned to be what I later found out. Because I bought this pawpaw, and as soon as I got back, I said, oh, let me start with it. Before my very eyes, it was as if it was just melting. Just very fine, oh, beautiful. So I don't know. It's really, sometimes it's very difficult to, you know, identify the food that is artificially, you know, ripened, especially. Yes, except maybe you buy the green one to ripen by yourself. So, but as for banana, that one is a bit easier. But pawpaw, very difficult. Okay, thank you very much. So at this time, I will call on Professor Tango to take off from here. Present. Okay. So we call on the provost to present a memento to the it's actually correct. Whether it is memento or memento. I saw that both, yes, I saw that both are correct.
Thank you, the chairman of this session. It's my pleasure to present this to you, ma. I was asking my colleague who sat beside me how we can modify our gari and soup to Mediterranean diets. So thank you for what you've done. I'm sure we have learned a lot from that, and we'll take caution in how it is. Thank you.
I think we can do fellowship after fellowship.
No, I was actually expecting somebody to ask me how will our own diet be Mediterranean. You know, like I said, the Mediterranean diet has a lot of fruits and vegetables. And if you notice carefully, fruits are not part of our diet. Well, at times some of us take them as snacks, and we don't remember to, or at times we don't even include them in our meal pattern for the day. We have what we call guide, and in the guide we have our roots and tubers. I think that is where we have issues, because we eat a lot of this carbohydrate, starchy foods. But if we can limit, try and eat a lot of the grains, whole grains, not the highly processed white flour, but the whole grains that still have part of the aloron layer on it, it will help, because they are more nutritious and yes, they are more nutritious, and add a lot of, increase the quantity of, we already have our dietary pattern, so I can't imagine somebody just in Nigeria and just eating only vegetables, because you can see a white person eating just vegetables, assorted vegetables, little meat, and maybe one slice of bread. We may not be able to do that, but let's increase the quantity of vegetables we put in our food. If you are eating rice, make sure you have ample vegetables. It doesn't have to be salad every time. We have green, we have ugu. There are different vegetables that we can always incorporate into what we are eating, and make sure we reduce the highly refined starchy staples, eat whole grains, add whole grains. And if we also try to adopt something that is close to the Mediterranean diet, I think it will also help us to reduce weight, because I think, and then oil, our oil, the quantity of oil we put in like our plantain. Plantain pottage is a nice food. If you put, for me, it's good. And it's a meal that, can help you not to increase blood sugar. But if you look at the amount of oil that we put, maybe if the oil is not flowing by the side, it doesn't look as if it has been well cooked. We can reduce those things, reduce the oil we put in our fan and things like that. So some of our foods are already good. They've kept us alive, but there are little things we can do to improve on them so that we will not have these metabolic syndromes. Thank you.
So thank you very much, Prof. I think with that, we can round up this particular session. Dr. Oka. And another thing, we also need to control the way we use bouillon cubes. We add a lot of bouillon to our foods. I mean, talking of Maggi, Knorr, and the rest of them. I can't even remember their names because I don't use them anymore.
Good morning, everybody. I want to add to what our mama had just said. That calls for nutrition counseling. People have money, but they don't know what to eat. Yeah, the nutritionists are everywhere. Consult them if you have a problem or doubt on what to eat. They will guide you on what to eat. She just talked about Mediterranean diet. We also have what we call African diet. The African diet is just like Mediterranean diet. We have a lot of vegetables around, both wild and the ones that we know. But in the wild, we have a lot of these vegetables. Nobody is talking about them. Some are even going extinct. And then these vegetables in the wild, they are cheap, they are affordable, with a lot of phytochemicals that help to fight infection. Why don't we go back and begin to eat what our forefathers are eating? Because we are no longer eating them. They are in the bush. I remember my PhD thesis was these edible wild vegetables. They are now in the wild. When I went to the bush to collect them, they are now calling me a herbalist, a native doctor. I say yes. But when the analysis was conducted, we saw that most of them are nutrient dense. So these things will help us to keep fit and leave the Western diet alone. They are even wanting to follow our own diet. Why are we rushing to follow their own diet? So the call is that we should consult the nutritionists. They are here and they are everywhere so that they can help us know what we eat and we'll live healthier. God bless us.
Well, what you said now, you said nutrition counseling. I put it back to the department. Create a time and a day and designate it like that and publicize it so people can come to you and start off something. From there, can grow on to something else.
Wow, you can see how engaging this session was. Yes, we are doing very well. Let's once again put our hands together for our distinguished lecturer for that thought-provoking, lecture. Thank you so much, ma. The committee, well, let's not praise ourselves. So the committee, will go out for the very best in their specialty areas, bringing out the current front burner issues. In fact, you needed to be in the presentation yesterday in the afternoon session. How so engaging. For the first time, I learned that mosquitoes can actually be, you can breed mosquitoes. Yes, for the first time, I didn't know that. So somebody is able to culture, mosquitoes over 2,000 in a particular environment for research. Here in this Calabar, not somewhere else. So there's so much for us to learn. Thank you. Thank you. So you do yourself good to participate in all the sessions. So now we are done with the plenary session for this morning. So the next thing that will happen is that for those of us who are all registered, of course, at the table out there you've seen, we've given you out a schedule, both the soft copy and the hard copies. So you know those we are going to begin the morning session of the scientific session, which begins immediately. So there are people who are going to be in this hall, and there are those who are going to be in the college meeting hall. The two sessions will run concurrently. So on the table out there, if you are registered, of course, we've sent this out 2 days ago. The hard copies are there for you to know where you should be as we begin this other session. So the people who will chair this session, okay, permit me please to recognize most of our senior professors who are here. Please, as a professor, wherever you're seated, can you just stand for recognition? Let's put our hands together for them. I can see, yes, the Dean of Dentistry. Thank you, thank you, thank you, thank you, thank you so much. Yes, we are so happy. Now we know that it's a full academic, yes. And then any other lecturer from another university, you want to also be a professor. Let it not be that I recognize only professors. Yes, senior lecturer, lecturer one, academic staff, wherever you are, please can you rise? Let's recognize you specially. Stand on your feet. Beautiful. Thank you so much. Thank you so much. Now we know that you don't do research as an academic staff. You have to involve the lab person. You have to involve admin, all categories of staff. So all our teaching staff, very distinguished members of the college or from any other part of the university, if you are here, can you stand? Let's recognize you specially. Please, let's put our hands together for them. Thank you so much. Thank you so much. We won't be able to communicate our research without you, And then how about our colleagues from the lab? The academic staff from the lab, where are they? The technical wing. Let's put our hands together for them. I can see Florence there. I can see. Oh, beautiful, beautiful girl. All right. Thank you so much, all of us. How about the students? Please, let me not. We have students here, both PG, undergraduate students. Can you stand? Let's recognize you specially. Beautiful.
Thank you so much. Thank you so much. You did very well for coming. I just remembered. I want to specially recognize one particular participant in this conference. She came all the way from Funai. And if you see her, you will appreciate that she came all the way from Funai. Please, Chinechere Blessing, can you greet us? Oh, okay. The provost is asking what is Funai. Tell us the name.
Alex Ekweme Federal University, Ndufaleke, Ebonyi State.
Alex Ekweme Federal University from Igbo. I think that's the I there is Igbo or something. Okay, Ndufu Aliko. Okay, beautiful. So thank you so much for making it not a local program. We have other people. Actually, they will be presenting virtual from different universities. So when we begin the scientific session, you'll see that it's not just a unique matter. Of course, you know that we are live. All right, so for this session, the people who are going to take up right here, whereas I'm calling the name so that you know where you should be. So here in ASU Secretariat, the people to chair this morning session will be Professor Essien David Oku. Incidentally, I saw on our platform this morning that this day is very special for him. It makes the 32nd wedding anniversary for him. I thought he should be somewhere with his wife, but he still had to come to show how special this program is. So please, Professor Essien David Oku, please kindly come forward to take your place. To co-chair the session with him is Professor Bob Ingbeje, the immediate past head of Department of Biochemistry. Please. Then we have Dr. Mfoniso Udokan. Where is she? Please come join them in the table. She's a member of that team. In fact, this was our all-round best presenter last year. Where is she? Is she here? Please, let's put our hands together as we take for her as she takes her seat. We also have Dr. James Edet Agbo. Is he here? Dr. James Edet Agbo is the rapporteur for this session, the morning session here in ASU Secretariat. Join them in the high table if he's not there. Then, the other side, these are the people who will chair the morning session in the college meeting hall. We have Professor Vincent Udon from Ecology, Professor Augusta C. Nsonwu Anyanwu, she's sitting right. Oh, where is she? I thought I saw her here. Beautiful. So that is a chair and the co-chair for the other session. Dr. Teresa Isamo and Dr. Deme Edet Ekong will be the rapporteur for that team. They will be heading the team in the college meeting hall for this morning session. Then in the afternoon session, right here in this place, we will have Professor Friday Ubo, I've seen him somewhere there, and Professor Richard Panepon. They will chair and co-chair the session here. Dr. Boniface Ago and Dr. Eze Adindu. Those are the people who will moderate the presentation here in the afternoon. That session begins by 2 o'clock. And then we have this other team that will moderate the afternoon session in the college meeting hall. We have Professor Lydia Abiabasi and Professor Ondubusi Chaganam, and then Dr. Ekberoni Esu and Dr. Adeyemo. So that makes the team for the afternoon presentations over in the college meeting hall. For the presenters, you already know yourself. So we are beginning right now, immediately. So if you are I'm sure some will be there already because I had some calls. Yeah, we are here and students are there. So I'm sure they know themselves. They are already there. So if you are not supposed to be here, you can join. But please, don't go. The presentations are quite engaging. You have 1 or 2 things to learn from it. It will shape and modify your research. So immediately, I want to hand over to the moderators of this session. I'll give you. Then, I needed to say this. We have very handsome award for best presenters. There are 3 categories. So when you are presenting, you need to know that I didn't have to call those names out. So you know. You have silent assessors who are assessing your presentation. So at the end of the day, we have best presenters in the first category, which is staff. Then we have best presenters in the category of PG students, and we have best presenters in the category of undergraduate students. So we have 3 categories. You are assessed. In fact, seated here was our best all-round presenter last year. She's here. She's been promoted. You are very well recognized.
Thank you very much. Good morning. You want to? We want to hit the ground running. I deeply appreciate you for being here today. Okay. We are told that we have 5 minutes presentation, 1 or 2 minutes to interact. So you have a maximum of 7 minutes per presenter. I would want to, please, can you call the first? I don't even know. The one sticks. Does it mean the person is around?
Okay, good morning, everybody. The first presenter will be Edim Essen, who will be talking on, making a presentation on the investigation of the antibacterial potential of Elysium indica leaf extract on selected clinical isolate using hexane as solvent for extraction. Edim, is he here? Or whoever is presenting that group? Okay.
Good morning, my professors and senior lecturers here present.
So we know who is presenting, so everybody gets ready. After Edim will be Uwem Okonakpan. If you can just move to the front so that you won't have to take 2 minutes to get to the podium. Uwem Okon, is he around? Okay, he is. Then Robert Aniete, is he around? Yep. As you hear your name, please just come to the front. Lillian Aburime should be around somewhere. Okay. Ofyong AE. Deborah Akpeku. Agbiji Neka, this one. Effie Watt, UE. Eyam Lillian. Enyuan Holmes. Usan Akedo. Felicitas and Nam. Yes, sir. Akpet OE. NS Ikechukwu Eze. Ngwoke FC. Ajunwa LI. Omoyemi Ikotun. Idara Khan, Eze Adindu, I saw him around. Okay, so those are the people who are going to be presenting in this session. I hope you are all here. Please just arrange yourself in front so. Okay, we'll start with the two that we have. Edim, go ahead.
Good morning, my professors. Good
So
morning.
you have 5 minutes. You have been told that already.
I'm presenting on antimicrobial activities of Alona moricata leaf extract on respiratory tract isolate of Klebsiella pneumoniae. Introduction. Klebsiella pneumoniae is the priority 1 critical pathogen and major bacterial agent of hospital-associated opportunistic infections, accounting for about 1/3 of all gram-negative bacterial infections globally. The organism is often associated with multi-drug resistant infections and reported to develop antibiotic resistance to antibiotics faster than many other pathogens. Infections caused by Klebsiella pneumoniae are characteristically difficult to treat, with consequence of high morbidity, mortality, and even high cost implications. Overcoming the therapeutic challenge posed by this drug-resistant strain will certainly require the use of new antimicrobial agents with novel mechanism of action against pathogens. Alona moricata is a fruit-bearing tropical tree belonging to the family Alonaceae, commonly known as soursop or gravola. Alona moricata plant extract have been used effectively in traditional medicine for treatment and prevention of many other diseases caused by bacteria such as pneumonia, diarrhea, and others. Statement of the problem. Antimicrobial resistance is a global health security threat that has stimulated intense search for alternative treatment modalities. In particular, Klebsiella pneumoniae infections, including those of the respiratory tract, are particularly difficult to treat and constitute a significant health burden, especially in hospital settings. Alona moricata plant extract have been used with remarkable success for treatment of various ailments in traditional medicine, but its efficacy against respiratory tract pathogens remain poorly understood. This study was an attempt to fill such critical gap in knowledge. Aim of the study. This study investigates the antimicrobial effect of Alona moricata leaf extract on Klebsiella pneumoniae isolate of respiratory tract specimen of patients attending selected healthcare facilities in Calabar. Specific objectives: to determine the antimicrobial effect of Alona moricata leaf on the study isolate using different concentration of ethanolic and aqueous extract. To determine the minimum inhibitory concentration of extract against Klebsiella isolate. To compare the antimicrobial activities of extract against the study isolate with that of commonly used antibiotics. Materials and methods. Alona moricata was collected in Calabar metropolis and it was identified by a botanist and a voucher number was issued. Let me run to the preparation of extract. The dry leaf of Alona moricata were grounded into fine powder using mechanical blender and subjected to successive ethanol and aqueous extraction using Solex extraction methods as described by Charadel et al. 2020. Collection of bacterial isolate and preparation of inoculum. The study utilized a total of 32 isolates of Klebsiella pneumoniae previously isolated and identified using Vitek 2 compact system in the laboratory of University of Calabar microbiology unit. Antimicrobial susceptibility testing of Klebsiella pneumoniae isolate to Alona moricata leaf extract. Agar well diffusion method was utilized. Standardized inoculum of this test organism was tricked on freshly prepared Mulahinton agar. Hole measuring 6 millimeters in diameter were made on the inoculated agar plate using sterile core borer. Aligot of 0.5 ml of each dilution of the extract, 200, 100, 50, 25, and 12.5 milligrams were carefully dispensed into the respective agar wells. Meriponin of 10 micrograms disc was placed at the center of each plate that contains the 0.5% ethanol as positive and negative control respectively. The agar plate were incubated overnight and examined for bacterial growth. Zone of inhibition was measured in millimeters. MIC was also determined using broad diffusion method. Antimicrobial susceptibility testing of the isolate. Capybara method was used for this. The data were analyzed using SPSS 25.0 software. Chi-square tests were also conducted. One-way ANOVA was also used. This is the result. In this research, the higher concentration were more effective on the isolate use, both in the ethanolic and the aqueous extract. Discussion. The antimicrobial potential of Allona moritata extract have been evaluated with promising results in many settings. In this study, concentration-dependent antibacterial effect was found for both extract against Klebsiella isolate, in consistency with previous reports of similar studies. Although the antimicrobial effect of both extract on the study isolate was quite minimal, the ethanol extract showed slightly higher efficacy, with 25% of the isolate susceptible at 200 milligrams per ml concentration compared to 18.6% for the aqueous extract. The difference in activities, though not weighty, may underscore the superiority of ethanol over water as extraction solvent for antimicrobial substance present in the plant leaf. Compared with water, ethanol has been reported to solubilize a wider range of compounds in the plant leaf, including volatile oil and other lipophilic compounds that may have antimicrobial properties. High MIC value of 50 milligrams per ml and 100 milligrams per ml, that is for the ethanolic and extract and aqueous, found for this ethanolic Allona moritata leaf may represent a modest antimicrobial potency against Klebsiella pneumoniae. These concentration values were higher than those reported for other plant extract against other bacterial isolates. The MIC value of the extract for the study may be attributed to presence of interfering substance that reduce the potency of the antimicrobial compound in the crude extract. Although seemingly minimal, the performance of both extract against isolate of Klebsiella pneumoniae may underscore a rich phytochemical profile of Allona moritata leaf consisting of polar and non-polar compounds with antimicrobial properties. Phytochemicals such as alkaloid, flavonoid, tannin, steroid, saponin, and phenolic compounds that act as antimicrobial have been associated with the plant leaves.
Time up. Conclusion.
This study found a concentration-dependent antimicrobial activities of Allona moritata leaf extract against genetical isolate of Klebsiella pneumoniae with MIC values suggesting minimal potency. Although the efficacy of the extract against the study isolate was far lower than the conventional antibiotics tested, its activities outperformed that of gentamicin. Optimization and the extraction process with isolation and purification of specific antimicrobial compound present in this crude extract will likely enhance its potency against bacterial pathogens, particularly multi-drug resistant isolate. Thank you. These are my references.
Okay, we're a little bit confused. were you supposed to be part of today's, or were you supposed to be part of today's presentation? Okay, yesterday. Okay. Because we're looking at our list and we didn't seem to see where. Okay, we just have 2 minutes. Anybody who has any questions for him, or if there's anything you were not clear about and you want some explanation, we just have 2 minutes.
In the absence of any questions, that would mean either you didn't hear much, you couldn't appreciate, or you really enjoyed it, and so there was no need to ask any question. Either way, it's not his fault. So please, let's encourage him. Clap for him. Thank you very much. We here on the table, we were a bit confused because we couldn't locate the position of his presentation on the list provided for us here now. But according to him, and we have also confirmed, he was scheduled to have spoken yesterday. So we still welcome him. Once again, please, let's clap for him. We are moving. Yes, we want to move straight to the next presenter. That should be Edom, the group headed by Edom. Are they here? No. It's not. See here. This one here. Investigation of the antimicrobial potential of Elucin indica leaf. Extract on selected clinical isolates using Hexane as solvent for extraction. Edom SN is the first. Is the person around? Hello? No. Next, the next person. What's your own? What's serial number? 32. Okay. Serial number 32, GATA1 protein red blood cell indices, and so on. Deborah Apeko. Are you the one? Please, can you come up? Thank you. Serial number 32. Please, let's encourage her. Please, you have 5 minutes, so you don't need to give us the exact way you presented on the slide. You're expected to summarize and go straight to give us your aim and objective, and then you did the work, the results, and comment on your findings. Do that within 5 minutes. Thank you.
Good morning, my professors. Good morning, senior lecturers, well-wishers. You're welcome. My name is Akepu Deborah, presenting on the topic GATA1, red cell indices, serum iron profile of HIV-infected individual attending University of Calabar Teaching Hospital. HIV has become a major global challenge, driving extensive research on its biology, transmission, prevention and treatment since the early 90s. These implications are associated with increased mobility, reducing quality of life and poor treatment outcome among affected individuals. The aim is to provide information on GATA1 protein, serum iron, red cell indices of HIV-infected subjects attending University of Calabar. The objective is to determine GATA1 red cell indices, serum iron profile of HIV-infected individual attending University of Calabar, to also determine if the intake of heart affect these parameters, to also determine if age or gender of these HIV-infected individuals has any impact on these parameters. The materials and methods. Study design was cross-sectional analytical design. The study area was teaching at University of Calabar Teaching Hospital. A total number of 90 subjects was being enrolled for this study, where 45 were HIV-infected individuals and 45 were apparently healthy individuals, which were friends, family, colleagues, etc. Now to the result. In the course of the result, based on the demographic data, the HIV patients who were above 40 years were over 64%, and the controls who were below 40 years were over 80%. Female definitely were more dominant in the both group, which is consistent with the epidemiology in Nigeria. When red blood cell indices of these HIV-infected individuals and controls was being compared, it was found out that the hemoglobin level between groups was similar. The red blood cells of the HIV-infected subject was reduced. Why? This could be because of the pneumocytic anemia. Now, the mean cell volume and the mean cell hemoglobin was elevated, which suggested macrocytic changes in their cell, possibly due to the heart intake, those drugs that these patients are taking. Now, when GATA1 and serum iron parameters was being compared between both groups, GATA1 here, there was no change between the two groups. It was constant. While serum iron parameters and the transferrin saturation was reduced, and the unsaturated ion binding capacity and total ion binding capacity of the HIV individual was elevated. Why? This is due to altered ion utilization or possibly ion overload. Now, when the age, the gender, and also the intake of heart duration was being compared between the red cell indices, the GATA1 parameters, and the serum iron profile, there was no significant change. There was no statistical change between these groups. This brings me to a conclusion where the study demonstrated that HIV infection and heart significantly alter red cell indices and iron metabolism. Now, despite stable hemoglobin, HIV subject had macrocytic changes, higher and altered iron profile, marked by increased serum and transferrin saturation, but reduced total ion binding capacity and unsaturated ion binding capacity. GATA1 protein was not significantly affected, suggesting its limited role in the observed hematological changes. Thank you very much.
Thank you. She tried her best to pray within the time limit. Please, let's clap for her once again. Come on. Where are you running? You would have to stand, and somebody can appreciate her if she presented well. Say something. Say something. No questions? Yes, is there anything you liked in her presentation? Just say something to yes.
Thank you very much. Beautiful presentation. Mine is very simple. I like the steeze, the composure in you. But science, as we all know, is not rigid. Yes, we deal with facts. So your choice of words, you were putting it to us as if another person would not look at it from the other way. What am I trying to say? Use words like probably, may. You understand? Don't tell us that, for example, in your conclusion, that GATA1, the last statement there, Another person might look at it from the other way and come out with something different. So that's just my observation. In summary, use words like probably, may. However, thank you very much. Beautiful presentation.
Thank you, thank you. It's all right. Okay, still on this. Okay, Professor Ubo wants to comment.
Thank you very much, the presenter. Just clarification. You have told us that heart was responsible for all the alterations in the iron, and this was a human samples. How were you able to control, one, what the individuals were eating, and whether they were on any hematinics? Were you able to control all those other factors to be sure that whatever you came out with was as a result of heart?
You got the question? Okay, you want him to repeat? She says she didn't quite get the question.
I believe you must have used females also.
Prof, please use the microphone.
I believe you use females and males. No, for the females, their iron level do fluctuate. I don't know whether you took into consideration their cycles, one, and the kind of drugs, medication that they weigh during the period of blood collection, and their diet, because all these are factors that can affect the blood iron level. How were you able to control these other factors?
How were you able to take care of these confounding?
Okay, so I want to get right. Is it for the HIV patients or for the control?
Both.
Both. Okay. The iron parameters for the HIV patient actually was the one that was low. Okay. Now, when it was being compared statistically from the table, because of time conference, it was divided into 3 tables. Those patients were divided into 3 groups. Those that started taking their heart drugs from 1 year to 3 years, 6 years to and above. Now, if you look at it as they were taking this heart medication, their regimen, as they continued taking it, there was actually a change through the chart. So the iron utilization here was actually, like I said, the serum iron and the transferrin was reduced, while the unsaturated and the total iron binding capacity was actually high. So it was commensurating.
Well, we will allow you go. Because, to my mind, you do not really appreciate the depth of the question posed by Professor Ubo, or it didn't occur to you at the beginning when you were designing the studies that there could be all of these confounding factors that may make what you're saying not tenable. Yeah, you didn't make any effort to exclude this, exclude that, so that whatever results you'll be getting will be attributed to the things you were manipulating. So you are a student, isn't it? We will allow you go. Thank you. All right, please. My colleague here will go through the list again. Perhaps when we were making the first call, either you were not listening or we skipped your name. This time around, please make sure that all the people available to present come over and sit in the front. Please go through the list again.
Okay, please listen to your name. First on the list is Eyom E. Okon. Edim, the next person, Edim Esen. Edim, do we have Edim here? Edim Esen, is presenting with Ina IO, Baby Aji, serial number 27. The next person is Uwem Okon Akpan, is here. Robert Anietie, E. Lillian Aburime, Ofyong AEA, presenting with Sunday Enidiok. Are they here? Please come to the front. Deborah Akpeku just presented. Agbiji Neka Ndifon. Is she here? Effie Watts, UE. Okay. Eyam Lillian Eberechukwu. Is she here? Margaret. Okay, the next serial number 34. You have done that. So the next person is Effie Watts, UE. Okay, is here. Eyam Lillian again. Whole Eyong one, Eyo. Okay. Usang Akedo. Usang Akedo. Felicitas. Ariam. That Ariam. Akbet OE. Okay. NS Ikechukwu. Is NS Ikechukwu here? Ugwueke FC. Okay. Ajunwa IP. Ikotung Elizabeth. Akpan Idara Ephraim. And the last, Adindu Eze A.
Okay, the next speaker is Ayo E. We're talking on the non-peripheral uterine inversion due to submucous fibrosis, a case report. Your 5 minutes.
Good afternoon, Chairman of the session. I stand on pre-existing protocol. Good afternoon, ladies and gentlemen. Mine is a case report titled Non-Puerperal Uterine Inversion Due to Submucous Fibroid. Uterine inversion is a rare but potentially life-threatening clinical condition. It's something that has a challenging diagnosis and management. Uterine inversion, by definition, is the prolapse of the uterine fundus to or through the cervix, and it's essentially turning the uterus upside down. If you think of the uterus as the avocado pear, with the fundus at the top and the bottom as the cervix, it will give you an idea of what uterine inversion is. It can be classified as puerperal or non-puerperal. Puerperal occurs within 6 weeks after delivery. Non-puerperal occurs during the non-pregnant state, and that is the one I'm discussing. There's a diagram which we can't go into because of time. The case was a 37-year-old female who was referred from a peripheral facility to us. She had presented there 4 months before with history of heavy menses and painful menses. An ultrasound scan was done, and uterine fibroid was diagnosed, which was symptomatic. She was to come for surgery, which she declined for her personal reasons. She now presented 5 months later at the facility with history of profuse vaginal bleeding. Actually, it was her 3rd day of menstruation. She had been taking some herbal medication for 10 days, and then on this 8th day, while she was menstruating, she developed severe waist pains, lower abdominal pains, and then she had an urge to bear down. When she bore down, a mass protruded from her vagina, and she started bleeding profusely, for which she went to the facility in shock, and she was referred to a hospital. When she came, she was actually in shock with cold, clammy extremities, and she also had, she was markedly pale, and then we noticed a mass protruding from her vagina. Initially, the diagnosis was a pedunculated uterine fibroid, and emergency surgery was done. It was during the surgery that the diagnosis was confirmed to be a uterine inversion. And then what happened was that we now had to go back and extricate the uterine fibroid, and then did a laparotomy, and then we repositioned the uterus using the Holton's technique. Now, uterine inversion is actually rare. It occurs in about 1 in 20,000 deliveries, and even the puerperal ones even occurs even rarer. And so one has to be able to make a diagnosis of it, and diagnosis is more difficult when it is the incomplete variety of it. A pelvic ultrasound scan can be useful, but the best way to diagnose it is a magnetic resonance imaging. And in the index case, we saw that the woman presented with a case that looked like a uterine fibroid, but during laparotomy, we noticed it was a uterine inversion. Different modalities can be used in treating uterine inversions. Some are vaginal, some are abdominal surgeries, which I have noticed that the vaginal surgeries are the Spinelli's technique, and the abdominal surgeries are the Holton's technique and the Huntington's technique. In the case of the woman, we noticed that the uterus had invaginated up to the point of the cervix and pushed out the prolapsed submucous fibroid. And because of that, we had to do the Holton's technique, which includes the incision on the posterior part of the cervix, and then the fundus of the uterus is repositioned back, and the incision that was made was sutured. That is what was done in her case. And it was actually successful. She was discharged after 7 days. She was seen 6 weeks later, and she was in good condition. So I'm presenting this case because it's actually difficult to diagnose. A lot of times, non-puerperal uterine inversion is from a mass in the uterus. The mass can be benign, such as the one that we saw, which is the uterine fibroid. But sometimes it may be a cancer, such as an endometrial cancer. So it's very important that you don't just remove the mass, but you send it for histology. Because if it is due to a cancer, you know that she needs further management. And then in some cases, it may not be possible to retain the uterus, because some cases the uterus may have been damaged and hysterectomy may need to be done. So in summary, I have presented this case, which was successfully managed by an abdominal surgical technique, and she was discharged in good condition. Thank you.
Thank you very much. I want to appreciate you that you are only telling us the story. You see, there are some video clips, or before you are allowed to view, you are warned. It's a viewer's discretion. The way you are describing it is so fearful, but that you people were able to really handle it, and the person concerned is alive, is something that needs, We need to applaud you for that. Please clap for them. Uterine invasion and all other complications. I give you the room to the audience to also interact.
Thank you very much, Dr. Young, for your presentation. My name is Dr. Akpet, Department of Community Medicine. I just want to chip in that this case presented calls for early referrals. The referral center she made mention of, though she didn't give the name, the people there, let them know the type of cases they can handle and the one they cannot handle and refer on time. Thank God they didn't even go to tamper with doing anything which the experts have handled and the person are alive. But if they've done such a thing, I don't think we would have been here to present this case. So those that are here, please take the message. The people who are at the peripheral health center, let them know what they can handle and what they cannot handle. Early referral is key to this case. Thank you very much.
Any other? Okay, there's a hand behind.
Thank you, presenter. My name is Dr. Blessing Ibe. You made mention that ultrasonography can be used to diagnose uterine invasion. How do you identify the image features in cases of uterine invasion in ultrasound? And also, you can also throw more light on the MRI images. How do you identify uterine invasion in MRI? Thank you.
Sorry, there should be a third microphone. So that, Ori, now give. There should be a third.
Thank you for your question. In the pelvic ultrasound scan, that is a baseline diagnosis. It's not a very good one, but it can give an idea. If you put your probe longitudinally, it will show the inversion of the uterus. I was trying to tell you that you imagine the uterus as the avocado pear. So usually it sits up with the top of the pear as the fundus, and then the slimmer place where the stalk is attached is the cervix. So usually the radiologists are used to the normal orientation of the uterus, but they suspect an inversion where the fundus is not seen where it's supposed to be on the longitudinal view. So that is one thing that makes them suspect. And then in the transverse plane, they see what they call the bull's eye. You know, the bull's eye. It actually shows when the fundus is inverting. You know, I told you that there are 3 degrees of it. So it depends on where the fundus is. They will have an idea of the degree of uterine inversion. Then the MRI is actually the gold standard for diagnosis of uterine inversion. It shows what we call the flower pot or flower vase appearance. If you look at this vase now, and the top is supposed to be the fundus, and then we imagine that the fundus is going in, what happens is that the MRI will actually show that the fundus has gone in depending on whatever level it is. Usually, there are structures that are supposed to be attached to the uterus, like the fallopian tubes and ovaries. So in the process of invagination, it will pull them in, and they now will stick out of the top like flowers from a flower vase. So that is what is called a flower pot or flower vase appearance. So that is what the MRI shows, and it's actually better in diagnosis. But this situation, most of the time, doesn't give time for doing even ultrasound scan, except you have a mobile one. Talk of MRI, because usually they come in emergency situations. So most of the time is a clinical acumen that helps to diagnose. But once in a while, we have the chronic uterine inversions that allows you to use these modes to diagnose it and make the diagnosis before treatment. That is why I mentioned that most of the time the diagnosis is missed until you go into laparotomy and then you now confirm the diagnosis. Thank you.
Thank you very much. I will not ask you who paid for all of this, because I know typical UCTH scenario, somebody's rushed you need to go to here, get receipt, go here, do this before.
Well, we have a provision for emergencies, actually. Some of them come in emergencies, and typically in Calabar, some don't even come with any money. So when it's life-threatening like that, we have a provision to treat first, and thereafter, they can now make the payments.
Okay, all right. Thank you very much. Any further? Please, let's appreciate Dr. Eyong and her team. And I wish there could be something instituted for people to donate to that, because it's very critical. It's very critical, considering the fact that this person proved stubborn at some point. She was asked to do this. She said no, depended on herbal treatment and all of that. So coming to hospital, sometimes you face a lot of abuses. And all of, so I really appreciate your team for taking that step to save that life. So let's appreciate them once again. Thank you very much. All right, the next person, please.
Okay, the next presenter should be Robert. Is he here? Robert, physicochemical profiling and biological evaluation of tetraplural tetraptetra. He's not here? Okay. We'll do what? Jessica, I'm sure you're the one. Okay. She'll be talking on the dietary patterns and assessment of nutritional status of people living with HIV, attending voluntary counseling and testing in Oron, Akwa Ibom State. Is there a microphone there?
Good morning, professors. Good morning, doctors, lecturers, and fellow students. My name is Udoiwu Jessica. I'm a postgraduate student in the Department of Biochemistry, and I'm here to talk on the dietary patterns and assessments of nutritional status of people living with HIV, attending voluntary counseling and testing in Oron, Akwa Ibom State. As we all know, AIDS is also acquired immune deficiency syndrome, and it's caused by the HIV virus, which is human immunodeficiency virus. And the virus attacks the body's immune system, rendering it vulnerable to infection. And it is also characterized by damage, leaving the body powerless to fight any form of infection. And the effects of this HIV on immune system and nutritional status are particularly pronounced due to the absence of a cure for the disease. And also, individuals constantly face the risk of infection, other infections, which are detrimental to their nutritional status and immune function. And understanding the dietary patterns of this specific subgroup is essential for devising targeted intervention that address their unique nutritional needs. The statement of problem. Despite the recognized importance of nutrition for people living with HIV, there is paucity of research investigating their dietary patterns, nutritional status, particularly in the Nigerian context. There has been previous studies of nutritional status of different subgroups, but there had been no study on this particular subgroup in the location. And also understanding this, the aim and objectives. The aim of this study was to assess the dietary patterns and nutritional status of people living with HIV, attending VCT, attending voluntary counseling and testing in Oron, Akwa Ibom State. The objectives were to determine socio-demographic characteristics, to identify the predominant dietary patterns, to also assess nutritional status, and to explore the association between dietary patterns and nutritional status among people living with HIV. Materials and methods. The study area was the Oron local government, and the study design was a cross-sectional study, descriptive study, and it was made up of subjects already on antiretroviral therapy. And then the hospitals were chosen by a random sampling method, and there were 4 hospitals, 4 health centers, and including the general hospital of that location. And before sampling and inclusion, informed consent was sought, and also sample size was calculated at 74 using the prevalence rate. The major data collection instrument was by means of a validated questionnaire, and the dietary patterns were assessed using a food frequency questionnaire. And also participants were presented with a list of 16 food groups and were asked to indicate how frequently they consumed. Anthropometric measurements was also obtained using standard techniques. Our results, our socio-demographic information also showed that the age distribution and gender composition aligned with global epidemiology of HIV, which often affects particularly females, and also the age distribution showed that they were in their reproductive and economical active years, and also the dietary habits, it showed that they consumed a wide variety of foods, and the 24-hour dietary recall also showed that the most consumed food in the last 24 hours was the oil and fat, which you know that area is also a riverine area. And their dietary diversity score was calculated based on the food they had taken, and this dietary diversity score was generally high. And we know that the dietary diversity score signifies it also showed a high dietary diversity score showed that there is better nutritional adequacy, and it showed that there are intakes of essential nutrients, and that the people ate a wide variety of foods. The anthropometric assessments showed that they maintained adequate nutrition, and their BMI, even though we had a few that were above 30, their BMI were above 30, and a small percentage was also obese, which is above 30. This raised concern about the potential risk of overweight and obesity among individuals living with HIV, as excess weight can increase the health complications and impact the effectiveness of treatment. The physical activity and lifestyle of participants. The low prevalence of tobacco and alcohol use among participants was a positive finding, even though there were still a few that were still taking tobacco and alcohol, but it was also the tobacco use. Of course, we know that tobacco use is associated with increased risk of various health complications, including respiratory infections and the rest. However, efforts to prevent smoking initiation and promote smoking cessation should continue and also be prioritized in HIV care and management. In conclusion, the observed health-conscious behaviors, including high diversity score and engagement in physical activity, shows a population that is proactive in managing their health. And additionally, the major participants had a BMI below 25, indicating a normal healthy weight for individuals. It's also crucial to acknowledge the presence of economic challenges highlighted by lower monetary income, which may also impact their dietary choices and access to nutritional adequate food. Despite the challenges, the study underscores the importance of holistic approaches that address both nutritional and socio-demographic factors. Also, by leveraging the observed health-conscious behaviors and promoting access to nutritional food, targeted interventions can be developed to support optimum outcomes in this population. These are my references, and thank you for listening.
Thank you very much. You were on time. If I may ask, why did you go to Oron particular? Why did you?
Okay, why I went there was because I'm from there, and it's easy to communicate to the people in the language they understand. Because most of these people, it's very difficult to have a research with them if you cannot communicate in their language.
Okay, that's a positive one. I know it's a riverine area.
Yes.
And they eat a lot of fish.
Yes, Prof. It's also from their dietary choices, you will see that they eat a lot of oil and seafood.
Seafood, oil and seafood. Because somebody was saying that we add too much oil to our food the previous session. Now you're telling us oil.
No, I'm not saying that the oil and seafoods are good. I'm just saying that based on the research we did, they took a lot of that, and it's normal because in that area there's a particular soup they cook with the oil floating on top.
Which is what now?
They just call it oil soup. They just mix it with some fishes and all that, and then that's like the prevalent food that they eat in that area. Most of the fishermen that live there.
Okay, I will give. There are a lot more I would have loved to ask, but let me give the opportunity to the audience to also interact with you. Please, there should be a third microphone for the audience.
Thank you very much, presenter. I was so intrigued with what you were presenting. Given the group that you were interviewing, special group, how did you handle the ethical issues? Because I never heard you mention anything like that. You know, yesterday we were told that if you are doing your research, you don't apply for ethical review, your publication will never see the light of the day. So how did you handle the ethical issues in this you are presenting? your research. Thank you.
Okay, because the study was not an invasive study, it was just we did not take blood from any of the participants. We had informed consent. So those that consented to the study were those that we took.
Okay.
Please let me correct this error. It's not that until you take blood from somebody when you are doing research before you can ask for ethical clearance. Are you hearing me? I am the state chairman, ethical research committee. Mere asking somebody what's your name is stressful. How do you ask this name so that the person will not be angry and cause more and sue you for disturbing her peace? That is ethical issue. So please get it clear. Whether you are doing KAP, knowledge, attitude, practice, you must do what? Get ethical clearance. Because we are findings there will not remain in your cupboard. You have to publish it. If you are publishing an high impact factor journal, they will ask you for the ethical clearance, either the number or the letter itself. So please take that clear. Thank you very much.
Jessica, is the study ongoing or totally concluded?
This section of the study has been concluded, but there's another study that is also ongoing, which we have gotten.
In that same area?
Yes, in that same area, but which we have gotten ethical clearance for that other one. But this particular section has been concluded.
Okay. So, is there something that they can do to ameliorate? Yes.
That is, you breach the protocols. So you cannot get ethical clearance for this very study, except for another one. Except you want to carry the study in another place. You can now ask for ethical clearance for you to do the study in a different place. But for this very one.
Okay. Thank you. I was going to ask if there's any room for forgiveness. But
like I said, this study is still ongoing, and for the second one, we have gotten ethical clearance, and we are doing that.
It's okay. Thank you very much. Thank you. All right. Can we encourage Jessica? Thank you very much. The next one, please.
The next speaker is Ophion. Is he here? Okay. He'll be talking to us on the extent of hygiene knowledge and practices among senior secondary. Who? Oh, no, okay, yes. Okay, you are the one. Yeah, you are the one I'm calling now. Okay. The extent of hygiene knowledge and practices among senior secondary school students in Cross River State, Nigeria. Serial number 31, Ophion et al.
Which one did you say we skipped? No. Okay, see, these people confused us. They gave us a list where some has been ticked, and we are thinking they had presented. Maybe they ticked it for a different purpose. But please allow your senior, when she's through, we'll get back to serial number 28 or so. Please, carry on.
Thank you very much. Distinguished panelists and fellow conferee, I'm Dr. Mary Enidiok. I would like to begin by first informing you that the researchers of this work are from College of Education and the Faculty of Social Sciences. So our approaches and presentation of research may not be the same like that of the College of Medicine. This is a research work that was carried out to investigate the extent of hygiene knowledge and practices among senior secondary school students in Cross River State, rising from concerns on a frequent absenteeism of students from school due to illnesses like cholera, high blood pressure, high fever, and all that. Concerns led to the introduction or the initiation of the WASH program. By WASH here, I mean Water Sanitation and Hygiene Program. This program was initiated by UNICEF in 1990, but it was embraced by the Cross River State government in 2012. So for over a decade, this program has been on here in Cross River State. Now we picked particular interest in assessing the extent to which this program has been successful. That led to this research. And in conducting this research, 4 research questions were raised. Literature was conducted or explored for insights on the variables of study. The variables under study included to find out the extent of hygiene knowledge among the students, to also determine the extent of hygiene practices among the secondary school students, to explore the influence of gender on hygiene knowledge among the students, as well as investigate the influence of gender on hygiene practices among the students. Related literature was explored for insights on the variables of the study. The study used descriptive survey research design. The population of the study was made up of 16,662 SS2 students in Cross River State. Then we had a sample size of 558. A research questionnaire titled Environmental Sanitation Conditions, Knowledge and Hygiene Practices was used for data collection. This questionnaire was administered on the 58 sample students, out of which we were able to successfully retrieve 528 copies. That was what was used for analysis. The questionnaire was analyzed using descriptive statistics of mean and standard deviation. Now, the results from this analysis reveal that there is high level of hygiene knowledge among the students. It also revealed that there is a low level of hygiene practices among the students. The results also reveal that gender has no significant influence on hygiene knowledge. And then lastly, that both the male and female students have poor hygiene practices. Now, what this means is that after the introduction of this WASH program, the program was aimed at promoting environmental sanitation and hygiene practices among the students. And this program has been on in Cross River State since 2012. We needed to evaluate the extent to which this program has been successfully implemented. Now, there was concern that, okay, the female students are more inclined to hygiene than the male students. And so that was why we brought in the gender aspect into both the hygiene knowledge and practices. But the study revealed that all of the students, they are aware of what hygiene means, what they are expected to do. And so their level of hygiene knowledge is very high. But contrary to what they know, what they practice is completely different. Their hygiene practice is still very low, which is still why we are having prevalent rates of sicknesses among the students, having cholera, high fever, and all that. Now, investigation also revealed that it wasn't that the girls were more hygienic than the boys. Both male and female students had good knowledge of these hygiene facts, but both male and female students were not practicing it. So those were our findings. Now, based on these findings, the researchers recommend that the government, through the Ministry of Education, Ministry of Environment, and Ministry of Health, should organize regular workshops and seminars on safe environmental hygiene practices for students within the public secondary school. Thank you very much. And like I said, we are from the College of Education. Our approach to research may not be the same like yours. Thank you.
Thank you very much. The language of research at some point, you can interact very well. You said you did some statistics where you had to do with mean. You could still have gone ahead to classify your population and give us the mean and standard deviation. But it's okay, we appreciate you. The knowledge is high, but the practice is low. I know a little bit about WashCom because the program was integrated into local communities. If the outcome is what you are saying about secondary school students, how about the real interior communities where these projects were taken to? Are you thinking of studying that one as well? And then so that whatever you are recommending, you would make sure that it gets down to the root. Because what I'm thinking is, if the practice was rooted in homes, at homes, maybe you could have had a better outcome with the students that you are assessing in the school environment. You understand my concern? You want to say something? Say something. It's a problem.
You know, the concern that led to this WASH program was actually based on the school environment, the sanitation states of school. You go to most of the schools in Cross River State, you still discover that they don't even have toilets for the students up till now. So despite that, the fact that the students know that they have to make use of the toilets, there are no toilets for them to use. At the end of the day, they still go to the bush. They know that they are to use toilet, but there's no toilet. So this helps, worsen the practice of hygiene for the students. They know they are to wash their hands, but the water is not there for them to use and wash their hands. Okay. So these were the challenges they explained.
You then see that your recommendations may not, workshops and all of that may not be the real thing. Because we attended village primary school. You go to the stream, fetch water, put it in a earthen pot in a corner. Each student you carry your own cup. You know, how come we were maintaining hygiene better then than now?
I'm not sure it was better then.
If it wasn't better,
hygiene practices,
I wouldn't be here. I wouldn't be here if it was not. If it was good. But what I'm trying to say is, you go to each of these secondary schools, some have boreholes. Maybe just buying fuel, pumping water to make water available. They don't do it. So what I'm saying is it's not just your recommendation. You say it should be workshops. You work, you shop, you work, you shop, but the work is not done. Highlights this, that the real thing is that there was no water provided and this and so that those facilities could be provided in the school environment, and the principals also, you know, do what is needful for the water to be available for students to wash their hands and observe other practices that are necessary. Okay, he wants to add something.
Okay. Well, I was just going to say that there's no amount of workshop that will improve the situation if the government does not provide the fund. I belong to Rotary International, and I know how many boreholes we have and toilets, complete borehole, toilet, everything were provided to. I can't count the number of schools, and there are still a lot of schools begging us to come to them. So I think the main thing is that the government is not doing very much, if anything at all, in that direction. I'm talking of Calabar now. We have not even gone to the villages, as it were.
So you go to the schools, you discover that even the toilets are there, but they are locked. The students don't have access to the toilets.
And they make parents give tons and tons of toilet tissues, a hypo, this clip, and brooms. So many things you in public schools. I don't know how we can come up with a strong advocacy against this. Parents pay so much. Tissue papers, toilet soaps, ISAL, and if you don't give, they make sure they collect those ones. And then school fees, they won't collect. They collect this one first. Then after how many weeks, they start driving those students for school fees. So these things the priorities are wrong. You see there? So Rotary, you're here. Because if you don't factor in all of this in what you're doing, you keep doing what you're doing, but it's not yielding the right results because of the implementation. Professor, please, say something.
Thank you, the presenter. I think I like the work, but at the end of the day, I was expecting the prevalence of, those who wash, those who do not wash, and all that. But above all, the recommendation, which you have, most of them have said, it should go to the government because they are supposed to make those things available for the students. So the recommendation is not for the students. It should be to the government. And I think if you escalate it, somehow, the Ministry of Education will be able to do something, either to monitor where they have the borehole and they are not using, or where they don't have the borehole, then they can do a borehole. So I think it can go beyond just finding out the prevalence, but then how can they improve the sanitation of the secondary schools in Cross River State? Thank you.
Thank you very much. Have you noticed something? Okay, while the microphone is traveling to that side, her presence here is adding flavor to the college conference. Somebody came here from Funai, and we said that is international, but this one is cross-cultural. How do you call it, please? Let me know from the ethical point of view.
Collaboration.
Collaboration. Please, let's clap for ourselves.
Collaboration.
Okay.
Thank you very much, presenter. I was so happy with this presentation. I am an expert in hand hygiene. That's why I was listening very well. Coming to your presentation, chapter 1 has to do with the background, introduction, and then the objectives, which are divided into general objectives and specific objectives. Literature review is not needed in this presentation because it's just an abstract presentation. So that is, I heard you talk about literature and so we were confusing the objectives. And one objective I was expecting to see is the factors responsible for this poor practice of hand hygiene among the students, which you didn't mention at all. Water availability, soap, and even the disposable hand towels. Therefore, the teachers, have they been teaching these students how to wash their hands? It's not when you want to eat, you use one hand to wash your hands, say they are done hand hygiene. No! There are steps, about 11 of them, for you to do proper hand washing. Then when it comes to your materials and methods, I wanted to hear you mention one of the analysis engines. You didn't mention, is it SPSS? Is it APINFO? And others. So please, Take note of that. Then your recommendation. That is where you're supposed to, when you talk about government coming in, first of all, they have to do what? Provide water. You talk about toilets. That one is environmental. This one is personal hygiene. As important as hand hygiene is, the WHO has designated 2 days the whole year to celebrate hand hygiene. That is how important it is. So let's teach our children the importance of this hand hygiene, and you see that they will be healthy in schools. Thank you very much.
Dr. Mary Enidio, I don't think you are expected to answer, but we just to take note so that next year, if you are coming, you won't give us any excuse again. You learn to be like we are, and then go back and shine better in your environment. Thank you very much.
Okay.
Please, can we
I'd like to say that I appreciate you for accepting me.
Okay.
All your criticisms, observations, and contributions are well noted for implementations in further research. Thank you.
Thank you. All right, all right. With that, we move to the next. We are going back to serial number 28.
Okay, serial number 28. Uwem Akpan et al. Evaluation of liver transaminase enzymes among women with preeclampsia, University of Calabar Teaching Hospital.
Good afternoon, professors, lecturers, and students. I'm Uwem Akpan. I will present on behalf of my team on the topic evaluation of liver transaminase enzymes among women with pre-eclampsia in University of Calabar Teaching Hospital, Calabar. Introduction. Pregnancy-induced hypertension, defined as blood pressure greater than 140 and 90 millimeters of mercury on 2 consecutive occasions, complicates approximately 10% of all pregnancies worldwide, and it also accounts for approximately 14% of maternal mortality. It is a multi-system disorder that significantly impacts pregnant women and their fetuses, which has been linked to dysfunction in the central nervous system, the liver, the cardiovascular system, the urinary system, as well as adverse maternal and neonatal outcomes. Statement of problem. Pregnancy-related hypertension, disorders such as gestational hypertension, preeclampsia, and eclampsia are prevalent complications that pose significant risks to both women and their fetuses. It affects about 5 to 7% of all pregnant women, but is responsible for over 70,000 maternal deaths and 500,000 fetal deaths worldwide every day. It is the leading cause of maternal death, maternal mobility, maternal intensive care admission, cesarean operation, prematurity, as well as morbidity and mortality of neonates. Studies, although inconclusive, have shown the association of liver enzymes such as AST and ALT levels with severity of pre-eclampsia, but little or no effort has been made to prove this association in Calabar. The aim of this study was to evaluate the levels of liver transaminase enzymes of women with pregnancy-induced hypertension in Calabar. The objectives were to determine and compare the level of AST and ALT of women with preeclampsia and controls in Calabar, to measure their blood pressure and urine protein of women with preeclampsia and controls in Calabar, to compare the level of these parameters based on trimesters and to determine the association between the above parameters in women with preeclampsia in Calabar. materials and method. A case control study design was used for this study. The study location was the antenatal clinic of the University of Calabar Teaching Hospital. Before subject enrollment, informed consent was obtained from the pregnant women and ethical clearance was obtained. A total of 60 subjects were enrolled into this study, comprising of 30 pregnant women with preeclampsia, which were the test subjects, and 30 pregnant women without preeclampsia, which were the control subjects. Furthermore, the test subjects were divided based on trimesters into 3 groups: first, second, and third trimesters. Blood and urine samples were obtained. Blood pressure was measured using the digital sphygmomanometer. The ALT and the AST levels were measured using the UV enzyme kinetic method with reagents obtained from Accurex Biomedical Limited, India. Statistical analysis was done using SPSS version 23. The student t-test, ANOVA, and Pearson's correlation were employed for data analysis with p-value less than 0.05. Result. Table 1 shows the comparison of H, blood pressure, AST, ALT, and urine protein levels in the pregnant women with preeclampsia and the controls. From the table, there was no significant difference in the age of the test subject and the control subject, while the systolic blood pressure, diastolic blood pressure, AST, ALT, and urine protein levels were all significantly higher in the test subject compared to the control subject. Table 2 shows the parameters are set based on the different trimester. We found out that there was no significant variation in the levels of all the parameters measured based on their trimesters. We also did a correlation analysis between the ALT and the diastolic blood pressure. We saw a significant negative correlation. And then between the 2 transaminase enzymes, we saw a significant positive correlation, which is expected because both of them go together. In terms of discussion and implications, there are several mechanisms that have been proposed to come into play for this condition. We have oxidative stress, where there are so many free radicals produced that overwhelm the antioxidant system in the body. There is also inflammation as a result of production of type 1 cytokines that increases liver inflammation and injury, which leads to the release of these enzymes. In terms of the conclusion, the study has revealed that there is significant elevations in the AST and the ALT levels in this subject. However, we did not notice any influence of the trimesters on the estimated parameters. And so we recommend that this patient should be on monitoring because this condition can be associated or may be associated with adverse maternal and fetal outcome. Thank you.
Okay, thank you very much for the presentation. Well, I was just going to say, yes, we're all in medical school, but you assume that we all knew what eclampsia was. Eclampsia, so you just imagine that we all knew what eclampsia.
Yeah, I define it from the introduction.
I didn't hear you defining it.
Pregnancy-induced hypertension.
Oh, okay, okay. So are there any questions, please?
Thank you very much for your presentation. I'm an obstetrician, so I'm very interested in that, your presentation. Interestingly, there is no obstetrician among those that did that study. I believe that it had affected even your definition, because actually you cannot make a diagnosis of preeclampsia until after the 20th week of pregnancy. So first trimester has nothing to do with that definition. And then from 20th week of pregnancy, which is well into the second trimester. And then eclampsia and preeclampsia are different, please. Eclampsia has to do with convulsion or seizures, that also occur in somebody that has the high blood pressure. So please take note of that. Thank you.
Thank you very much, presenter. In the course of your presentation, you made mention of a work that was not concluded. It is not supposed to be. You present only work that has been concluded, so I can reference it very well. And then you made mention of ethical consideration. Ethical clearance was gotten from where? Because it was from me. I have insisted that an obstetrician be in your research team. That's what we normally do. And because we are taking blood, we don't joke with ethical clearance when invasive procedures are involved. So where did you get your ethical clearance?
Thank you very much for the contribution and the question. When we talk about study being inconclusive, we are looking at the controversies that surround the particular subject matter. For instance, some people may carry out a particular work here in Calabar, and they find out that the outcome is different from what another group does in another location. So there may be conflicting outcomes. That's what I meant by inconclusive. Maybe I would have used controversial. Then in terms of the ethical issues, we did work with obstetrician in the UCTH because I worked with some undergraduate students. So we did contact someone there that helped us. And then for the ethical clearance, it is from the UCTH because we can't get it outside there. Although I didn't include the number, I would have included the number on the methodology. Thank you very much.
Are there any more questions? Okay, somebody behind. Right at the back.
Thank you very much, presenter, for that wonderful presentation. Mine is on your statistical analysis. You did mention that you used student t-test ANOVA. So I want to understand. Can you throw more light on that?
Okay, when we talk about student t-test, we are comparing variables between two groups. If you check the first table, it had to do with the study group. That's the test subject and the control subject. That's where we use the student t-test. While for the ANOVA, has to do with comparison of variables from 3 groups and above. If you are comparing variables from 3, 4, 5 groups, you can use analysis of variance. That's what we did. Thank you.
It's okay. The person who asked that question, did you register for this conference? Because I want to recommend you pay double for what you... He's using you now to teach him statistics, but it's okay. That's why you are here. So let's encourage him. Thank you very much. Thank you. He delivered like a pro. Okay, let's get on to the next.
Agbiji, are you here? Agbiji? Effie what? Okay. Ms. Effie Watt is here, and she will be making a presentation on the determinants of use of natural and traditional family planning methods among women of reproductive age in Akum community, Calabar municipality, Cross River State, Nigeria.
Good afternoon, professors. Good afternoon, lecturers, doctors, and fellow students. My name is Jemima Atsu. I'm a final year medical student of the Department of Medicine and Surgery, and this work was our project work, which we carried out this year with my colleagues and with supervisors. And the topic is determinants of the use of natural and traditional family planning methods among women of reproductive age in Akim community, Calabar municipality, Cross River State. And I'll be doing it under the outline: introduction, justification, objectives, methodology, results, discussion, conclusion, recommendations, and then the references. Okay, for the introduction, first of all, what is family planning? According to the World Health, family planning enables individuals and couples to determine the number, spacing, timing of children using various contraceptive methods. Before the advent of modern contraceptive methods, communities relied on natural and traditional practices such as withdrawal, prolonged breastfeeding, herbal mixtures, charms, withdrawals, and the rest. But currently, it is being classified into modern, which involves pills, injectables, implants, the intrauterine devices, then natural, which involves the rhythm methods and all of that. Then the traditional methods, herb charms, and the rest. So approximately 20% of couples, African couples, rely on the natural and traditional methods, which have been found to be linked to unintended pregnancy rates. And of course, because of the unintended pregnancies, this will also lead to people looking for means to get rid of the pregnancies which they are not interested in, and then which also leads to unsafe abortion, which of course increases maternal and child mortality and morbidity. Previous studies concerning family planning methods were institution-based, so we had to carry out a community-based approach, go into the community, and then find out the reasons why this goes on. So a community-based study is supposed to help us discover the health practices and needs within the local population. This study was carried out in Akim community, Calabar municipality, Cross River State, and a cross-sectional descriptive study design was used. And the study population included women of reproductive age in Akim community. For the inclusion criteria, usually the women of reproductive age normally are supposed to be from age 15 to 49. But because of reasons for obtaining consent from those below 18, we decided to use women from 18 to 49. A total of 421 respondents were used. Then we used the cluster sampling method, used interviewer-administered semi-structured questionnaire, data analysis using the statistical packages for social sciences version 25, and then the ethical consideration was gotten from the University of Calabar Health Research Ethics Committee. The social demographics, the overall mean age was 31 plus or minus 7.8. Marital status was 44.4%, religion and all of that, did the social demographics. Then the overall knowledge score, the study revealed that a high level of knowledge of family planning methods were known among the participants. Then the purpose, 59.9% knew that the primary purpose of family planning is to space or limit childbirth. Then a large population were aware that family planning can be obtained from health facilities, while 29.7% believed that you can also get family planning counseling from religious leaders. With regard to effectiveness, 49.2 believe that natural planning methods are more effective than the modern methods, while 97.3% disagreed on the traditional methods. Furthermore, 50.1% reported feeling more comfortable using the natural methods, and most of them prefer these methods because they do not include medication or the use of devices. Out of the 311 respondents that have reported using natural and traditional farming methods, most of them gave reasons because of the fear of side effects of the modern family planning methods, then the partner's influence, and then not enough knowledge on the modern methods. Only a small portion of respondents reported ever using the traditional methods. Then a statistically significant association was seen between the age group and the use of natural planning methods. Then marital status was also associated with a higher population of married women and those cohabiting using these natural methods. Occupation was also associated with housewives reporting the highest percentage of use. There was a high awareness of the family planning methods, then the knowledge varied, but of course the awareness did not translate to use, as it has been considered with previous studies. And it also showed that even if they are aware of these methods, because of the associated drawbacks or stories that they've heard regarding modern family planning methods, they were not interested in using these methods, and so most of them continue to rely on the natural planning methods, which included the withdrawal, rhythm or calendar counting method, and the rest. In conclusion, this study demonstrates that while awareness of the family planning is high in the community, the knowledge varies and the choice of method is heavily shaped by socio-demographic factors, personal beliefs, partners' influence, and the cultural norms. Natural methods remain widely used due to fear surrounding the modern family planning methods and the perception that these natural methods are safer, non-invasive, and are culturally acceptable. The low uptake of traditional methods shows that even while cultural heritage still plays a role, people shift more to the natural method, which is seen as an in-between between the modern methods and the traditional methods, where they do not trust the traditional methods, but also while they do not trust the modern methods, they are safer using the natural methods, which are non-invasive. Recommendations, we recommend that family planning programs should provide culturally sensitive counseling, then improve access to these modern methods, involve partners in the decision making, and then also address information regarding the modern methods. Then future researchers should also explore the role of partner involvement, cultural beliefs, and fear of side effects in women's continued preference for natural methods, despite the awareness of modern methods. Thank you.
Thank you, Efiwat. When was this study conducted?
Between April to August.
Which year?
This year.
April to August this year. Your ethical approval that you showed here says so number stroke 2012. So I was wondering, does it have to do with the year? Ethical approval. Can we go back to?
No, it does not have to do with the year.
Let's see it. So if you see it in a publication, so that you help us here. But this one I saw 2012. That's why I took notice.
From the hospital. I have a picture of it here. I can show you. It's correct, yeah.
Let's just see. Let's see. It's here. I want us to clear something. See, 10, 7, 10, 12. It just attracted my attention. This is University of Calabar Health and Research Ethics Committee. 7, 10, 2012. Does it have anything to do with the dating?
Yes, I have the letter here.
Okay, so this number, this reference number, it has nothing to do with the year. I hope you all agree with us. Agree?
Okay. Sit here.
No, I'm not doubting, because as I'm asking here, somebody in China or anywhere, you're publishing and you got ethical approval, and it's like a date, 10/7/2012. So you find another way of writing it so that you will not raise this kind of question, because you will not be there breathing over the shoulder of every reader to explain that it's not the dating. Otherwise, it would mean that you got something and you were just imposing it on the reading public. All right then, thank you very much. Please, you are free to ask questions. Dr. Young, you want to say something?
Thank you very much, and well done to your team. I can see that our final year students are doing very well. Family planning is actually an area that we have been struggling with. Women, for some reason, are very afraid of family planning. We do all the counseling, send them to the family planning clinic, and a lot of them still hear stories. Oh, my sister, my friend, they did this method. She became very fat. She became very slim. She was bleeding too much. She was not menstruating. You know, and they hear all these stories, and then they don't even want to try the modern method. So what she's saying is actually true. A lot of people know about these methods, but they are not in a hurry to try them. And that is why a lot of times these natural methods, the failure rate is definitely much higher. And a lot of them end up, having unplanned pregnancies. And unfortunately, what she has not said is some of them use abortion as a means of family planning, in quotes, because some of them, by the time they get pregnant, when they don't desire children, sometimes they come to us and they say they want to do an abortion, and we tell them that we don't do such things. Unfortunately, it's out there in the open that there are drugs that you just swallow and then you start, bleeding. And once the process has started, they come to us. We have no choice but to complete it for them. So it's actually a big problem. There's a lot of work still to be done in family planning because our women are actually not very, receptive of the modern methods of family planning. They still want to do the natural methods, which, the rate of failure is quite high. So that is the situation. Well done to your team once again.
Thank you very much, Presenter. I didn't want to ask this question, but from what Dr. Ian was saying, I have to ask. You talked about the natural method, which you gave examples. We didn't hear example of the traditional method. Please, can you mention some? Let us know.
Examples of the traditional method includes the use of herbs, amulets, charms, padlocks. They have been reported in previous studies.
Now, was there anywhere, sorry, in your study, did you actually test the traditional methods? You got a group that was using traditional methods and then you get the outcome. Or you were just mentioning them, like we are mentioning them now.
Yeah, we just asked, we did not test.
Okay, further research. But then I am worried about your recommendation. Partner participation. Partner. How is that? If it's husband and wife, then fine. But the people that we are looking at, did you pair them to, or was there any possibility of identifying partners so that you can bring in studies?
No.
So if you are going to a field, how do you expect to get partner participation? Sex partners to come and participate, to come and listen to you. Is it possible?
Yes, if we advocate for the women to come to the hospital first, if we advocate for the women
advocate.
If we tell the women to come to the hospital.
With their partners. They will come.
We will let them know that this family planning.
I'm wondering how you go to get at such a group who will follow a girl. How many will come for one girl? Anyway, some of these things are easier proposed, than implemented. Ask a girl, come, we want to do a study, come with all your partners. Is it really possible? Okay, thank you very much. Please, let's clap for her.
Okay, well, presenters would just have to take permission from you to call in a breastfeeding mother. I think the baby is a little bit fidgety, so we just thought we should crave your indulgence to allow her participate. Make her presentation. I think Seth is participant number 42, but it's not exactly the name I have here. Yemi Ukotun, where's that? Yemi, please, have you looked at the list? Okay, just come and make your presentation. Maybe we'll find out exactly.
Serial number. Hello? Come. Are you Ajungwa? Ikotu? Is her name, is she listed here? Are you? Serial number what now, please? Okay. Is your baby a male or a female? Is your baby a male or female? I want to know. Female. Okay, right, since it's a female. It was a male.
Good afternoon, professors, doctor, lecturer, and my fellow students. My name is Elizabeth Omoyemi Ikotun, a master student of Biochemistry Department. I'm here to make a presentation on the topic, the nutritional composition and storage study of a cocoa wheat-based snacks enriched with Bambara groundnut flour. I have my outline here. Introduction and background of the. Okay, sorry. Why the need for the fortification of cookies? I'll be speaking majorly on cookies because this is the major work I did. Because cookies and biscuits are the same, they're just a little different from the two. So why the fortification of cookies? Cookies is highly accessible and a stable snacks in Africa, or majorly in Nigeria here. So it is accessible. Almost everybody hates cookies. So why the fortification? Cookies, as we know, that they are majorly produced from wheat. And there are other legumes that can be used which are more of nutrient and nutritionally beneficial that can use to combat protein energy malnutrition. So this brings about this study of using Bambara groundnut flour in supplementation with wheat. And also the cocoa powder used here is used as an enhancer to enhance flavor. And also the cocoa powder has a mineral nutrient, and as well it has a beneficial antioxidant. Statements of the problem. The aim and objective. The aim is to develop a highly acceptable, stable, and nutritionally snacks from school composite flour of Bambara and wheat. The objectives are to evaluate the proximate, the mineral and anti-nutritional composition, and also to determine the physical properties and the microbial safety. Then Lastly, to assess the sensory acceptability and the storage stability of the cookies. The material and method. The material used is Bambara granite seed, which is soaked for 12 hours, dehulled and dried. Then after that, it's being milled into flour. Then the substitution is made in the ratio of 100% of wheat, which is the control sample, and 70% of wheat with 20% of Bambara granite flour and a fixed amount of cocoa powder for all the formulation, a 10% amount, a fixed 10% amount for cocoa powder. Then the other formulations are made with 65% of wheat, 25% of Bambara, then 60% and 30% of Bambara granite flour. The key analytical procedure used, the approximate analysis, AOAC 1990, atomic absorption spectroscopy, microbial evaluation, sensory analysis using a 9-point Edoni scale. Then the results of this nutritional enhancement. From my bar chart here, we see that protein increase with increase in the substitution of Bambara granite flour, which is AD. AD has 60% with 30% Bambara granite flour. So this product is more acceptable and is highly nutritious than other formulation. And also the formulation is rich in potassium, calcium, and flavonoid content. The flavonoid content is higher in sample AD, which is that of 60% with 30% Bambara granite flour. I have the sample of the cookies here. Nutritional composition. The time I gave it to them. No, I did it 10 years ago, sir. I made the product 10 years ago. For my flow chart here, I can see it shows the sensory evaluation of the cookies that the higher substitution of Bambara granite flour is highly acceptable than other substitution. Discussion. The high nutritional benefits of 30% Bambara granite substitution is achieved without compromising or even improving consumer preferences. All fresh and stored cookies were in safe microbiological limits. Then the implication of this study is that this product is nutritionally excellent and consumers prefer, suggesting strong market potential. So there is need for diversification of wheat using Bambara granite flour. Bambara granite flour is highly nutritious and it has more of protein than that of wheat. And also from the results, there is decrease in carbohydrates with increase in the substitution of the Bambara granite flour. Then protein content increases proportionally to Bambara substitution, which I've mentioned. Then the product produced is high in mineral content like iron, calcium, potassium. Then the microbial load is within acceptable limits. The product was stored for a month, and the microbial load was within the microbiological limit, stored samples shows no significant deterioration across packaging material. So there is need for producers and manufacturers of baked products to incorporate Barbara granule flour in the production of their baked products. Conclusion: cookies production with substitution of wheat, with substitution of Bambara to a 30% level is significantly higher in protein, mineral, and antioxidant. The anti-nutrients, they are of limit standard. They have no effect on the bioavailability of the protein. And also, composite flour supports food diversification and reduces the reliance on imported wheat. Recommendation: further research should explore Bambara granule utilization for highly sensitive products like infant formulation and raw milk extraction to maximize its nutritional impact.
Time up.
Thank you.
I know it's going to be a little bit difficult to ask questions since the slides were not exactly projected. But if there's anybody who has a question or maybe some suggestion to beef up the presentation, the time is now.
My own pain is that we couldn't see the slides, and you couldn't also give me the cookies physically. Is this what we're supposed to be? Okay, but now, okay, is it what you said, Ukpa? What's this Ukpa? What's the local name? Ukpa, okay. All right, so you say 10%, is it 10% of this? 20% of
Bambara granule flour.
Which one was better?
30%.
30%, okay. She said 30% of this in that composite gave a better outcome, better cookies. All right, we look forward to having you produce this physically so that we can, in the department, say you are from biochemistry?
Yes, sir.
Okay. When your baby is a bit older and you are free, bring us the cookies. Thank you, thank you, thank you, thank you. And the next person, please.
Okay, the next presenter, Eyam Lilian, are we here? Lilian, Eyam, et al. Okay, if you're not here, Ayon Holmes. Okay, she's going to be making a presentation on the interconnection of metabolic disorders and mental health. 36. Strategies for integrated care and support.
Good afternoon, my professors, lecturers, and everyone here present. I'm Holmes Eyowaneyo, and I'll be presenting on the topic, the interconnection of metabolic disorders and mental health, strategies for integrated care and support. Before I begin, I would like to note that this topic arose primarily in focus of the theme of this conference, which is mental health and economic productivity, forging mental well-being in the face of crippling economic challenges. Introduction. Historically, psychiatric and metabolic conditions were treated entirely separately. However, recent research have established that this bi-directional relationship, excuse me, please. Historically, psychiatric and metabolic conditions were treated as entirely separate disease entities. However, recent research have established that this is a bi-directional relationship and a public health crisis. Patients with major mental illnesses face dramatically elevated risk for conditions like type 2 diabetes, cardiovascular diseases, etc. Please, I would like to skip to the aim of my study. The primary aim of this comparative literature review was to address the urgent need for integrated care strategies by examining the complex bi-directional relationship between major mental illnesses and metabolic disorders. The objectives of this study included to quantify the mortality gap and severe co-prevalence of metabolic diseases in MMI populations, to explain the shared biological mechanisms focused that prevent integrated treatment, to validate the collaborative care model as the superior evidence-based strategy, to formulate actionable policy recommendations for integrated care, implementation, and workforce education. Materials and method. The study design for this work was a systematic literature review. The primary searches conducted were across academic and medical databases as listed there. Systematic reviews, meta-analysis, and landmark randomized control trials were used for this study. I considered data that was conducted within 5 years. Opinion pieces, single case reports, and animal studies were excluded from this study. For my results on bidirectional risk and clinical outcomes, individuals with bipolar disorder or schizophrenia existed a 2 to 3-fold higher prevalence of type 2 diabetes and cardiovascular disease compared to the general population. Antipsychotic use significantly drives this risk. Metabolic syndrome is a primary driver of the 10 to 20-year reduction in life expectancy observed in people with severe mental illness. Increased ultra-processed food consumption is associated with a 20 to 50% higher risk of developing depressive symptoms, highlighting the behavioral metabolic link. Under shared pathology and mechanism, both MDDs and obesity are linked by elevated peripheral cytokines. These signals cross the blood-brain barrier, inducing neutral inflammation and compromising insulin signaling. Brain function is impaired by metabolic failure. The resistance in the central nervous system accelerates neuronal aging and is hypothesized as a mechanism for cognitive impairment and depression. Adherence and symptoms inference. Symptoms like aheduria and amotivation directly interfere with self-management. Study shows that addressing the psychiatric symptoms improve adherence to metabolic regimens. Patients face prejudice related to both their mental illness and their physical condition, which leads to avoidance of care and poor self-management. Under integrated care and efficacy, the independent randomized clinical trial demonstrated that collaborative co-models for patients and comorbid type 2 diabetes mellitus and depression significantly improved both depressive symptoms and metabolic control simultaneously. Meta-analysis confirmed that collaborative co-models is a cost-effective solution, often leading to lower long-term overall healthcare spending compared to fragmented care. Structured comprehensive lifestyle interventions are proven to reduce inflammatory markers and improve both metabolic and mental health outcomes. Discussions and implications.
Time up.
Conclusion. The study concludes that metabolic disorders and mental illnesses are critical clinical cases that arise from systemic immunometabolic dysregulation. It proposes that collaborative co-models are the proven and most cost-effective structure required to prevent diagnostic overshadowing and improve both metabolic and mental health outcomes simultaneously. My recommendation: investment in research focused on how to scale collaborative co-models successfully and sustainably across diverse low-income community settings. Exploring pharmacological agents that addresses the shared biological pathways to treat both conditions simultaneously. Encouraging cross-specialty literacy to address the lack of awareness barrier through training psychiatric in metabolic risk and primary caregivers in mental health literacy. Thank you.
Any questions for the presenter, please? Well, it doesn't look like we have any questions. Okay.
Thank you very much for the efforts for putting things together. Listening to you, I think the idea behind the presentation makes a lot of sense. But what was not very clear to me was the design of your work. Can you help us understand what design you used to do this work?
Thank you, sir. For this work, it was strictly a literature review, a review of literature that has been done on this topic. It was a systematic.
Okay. Any more questions? Okay, so we'll move to the next speaker. Can we give her a round of applause, please? And the next speaker will be Usam Akedo. You here? Usam? Okay. So he could be talking to us on the seroprevalence and co-infection of Toxoplasma gondii and HIV among mentally ill patients of the Federal Neuropsychiatric Hospital, Calabar. 5 minutes.
Okay. I am Usang Akedo, presenting on the seroprevalence and co-infection of Toxoplasma gondii among mentally ill patients at the Federal Neuropsychiatric Hospital, Calabar. Good afternoon, Chairman, professors, lecturers, and other students here. Toxoplasma gondii is an obligate intracellular parasite, protozoan parasite found worldwide. It causes toxoplasmosis, which is one of the world's most common parasitic infections, mainly amongst warm-blooded animals. Felines, those are cats, are definitive hosts, while non-feline vertebrates like man act as intermediate hosts. Humans become infected and contract this congenitally through poorly cooked food and prepared meals. And this can result in congenital, ocular, and cerebral infections, especially in immunocompromised persons, like HIV-infected persons. Mental illness is thought to be caused by a variety of genetic factors, environmental factors, and inherited traits. However, it's also known that in immunocompromised persons who contract Toxoplasma gondii, there could be some neurological involvement. The HIV rips man of his immune competence and opens one up when he gets to the, opens up the carrier to opportunistic infections, of which Toxoplasma gondii is one. The statement of the problem: there is a dearth of information on the status of HIV among mentally ill persons in Nigeria, while Toxoplasma gondii is an opportunistic infection that can be reactivated in HIV and AIDS, leading to toxoplasmic encephalitis. The aims and objectives of the study: the aim is to determine the prevalence of T. gondii and HIV among mentally ill patients in the Federal Neuropsychiatric Hospital, Calabar, using serological methods and establishing their co-infection. The objective of the study is to determine the seroprevalence of T. gondii using enzyme-linked immunosorbent assay method, that's the ELISA method, to determine the seroprevalence of HIV using the rapid diagnostic test kit method according to nationally established HIV testing algorithm, and to compare the prevalence of toxoplasma in HIV along demographic lines, gender, age. The materials and method. The study was carried out in the Federal Neuropsychiatric Hospital, Calabar, and between October and February 2023. The Federal Neuropsychiatric Hospital was chosen as a study area because of the availability of subjects for the study. The sampling method, the research is a cross-sectional study. Blood samples were septically collected from 150 patients. Test samples and 100 samples were collected from otherwise healthy persons as control. The samples were transported to the laboratory for analysis following standard laboratory procedures for ELISA and HIV-RDT. The inclusion and exclusion criteria: only mentally ill in and out patients at the Federal Neuropsychiatric Hospital were considered as subjects for the study. Ethical consideration was obtained from the Ethical Committee of the Federal Neuropsychiatric Hospital. Informed verbal consent was obtained from patients who couldn't actually, give us, from relatives of patients who couldn't coordinate themselves or give us any permission for the study. The results: 253 subjects were randomly selected for the study. 153 comprised the test subjects, while 100 comprised of the control subjects. The study showed that there were more test subjects reactive to toxoplasmosis, that is 79.7% prevalence, compared to the control subjects that came up with 47%. There were more seropositive to HIV among the control subjects, 14%, than the test subjects, which came up with 5.2%. The gross ELISA reaction to T. gondii and HIV seropositivity among test and control subjects showed that by gender, the males had tested more positive to gross ELISA than the females, 84.2%, compared with 63.6% for the females. For HIV, the females had a higher testing positivity to HIV, 9.1%, compared to the males, 4.2%. That is among the test subjects. For the control, the males also came up with a higher prevalence, 41%, which translated to 53.9% for gross ELISA, than the females that had 25%. And HIV, the females had 33.3% reactivity to HIV than the males that had 7.9%.
Time.
The other factors looked at were age, and for the test subjects, the range with higher prevalence of toxoplasma fell between 60 and above, with 85.7%. The age range with the least prevalence among the test subjects was that from the age of 20 years and below.
Conclude, though. Time.
And conclusion. This study has detected a high prevalence of toxoplasmosis, 66.8%, based on gross ELISA reaction amongst the population. The test subjects. A higher prevalence of toxoplasmosis was recorded among the psychiatric patients than the general population in Calabar. HIV infection was lower among the psychiatric patients, 5.2%, than the general population. The findings from this study has established the existence of toxoplasmosis and HIV comorbidities in mentally ill persons in the Federal Neuropsychiatric Hospital, Calabar. Recommendations. Toxoplasma Gondii screening should be considered as a baseline for persons admitted to psychiatric care. Screening of blood for transfusion, especially to known immune compromised persons, should include T-Gondii screening. Prophylactic treatment for owners of feline pets is advocated to prevent establishment of infection. Public health enlightenment and necessary oversight by regulating agencies for pet handlers should be enforced. My references, thank you.
Any contribution, questions for the presenter? Professor Albert.
Thank you very much, Usang, for your presentation. My first observation was that your slides were not customized slides. Why was that? You know, we are in a feast, academic feast. If you don't wear that uniform, you are not fit to be here. So please, take note of that. Then your presentation looks as if you were doing a comparative study. But the title is not like that. Because I heard you saying toxoplasma gondii was more among psychiatric patients than the other population. So please clarify that, because the topic doesn't reflect that it was a comparative study.
So your observations are noted concerning my slides not following the typical. I was running out of time and I couldn't download the format. The topic says seroprevalence and coexistence of toxoplasma gondii and HIV among the mentally ill patients of the Federal Neuropsychiatric Hospital. The coexistence suggests the results should be compared. That, okay, the fact that we have tests and we introduce test and control subjects also ensure that in our reporting results we compare for standards. That's it, sir. I hope. Okay. Okay. All right, sir. That's noted, sir. It's noted.
It's okay. All right, please, can we encourage him?
Thank you very much. Please, I have a question. I just want to find out. You said the toxoplasma is high in the psychiatric subjects. Is there any relationship? What's the mechanism? Why are there more in mentally, people with mental problem? Is there any relationship with mental problem and that particular parasite.
Thank you, Prof. I had mentioned that Toxoplasma gondii has a neurological involvement. The parasite established itself, and part of what it can cause, using the plain language, is that it affects. In fact, there are studies amongst rats, that have shown strong deviation from normal character when infected with Toxoplasma gondii. The studies are still on the mechanism for establishment and all that, but it is known. At this point, one would say, I'm working on HIV, as HIV progresses in pathology, it also has some neurological involvement also. So this work may not have been able to delineate that, but just to say that somehow we found that the two are existing in psychiatric patients, man. That's what this work would do. I don't know if I've helped in any way. Yes, ma'am. Okay, how it's contracted. Okay. It's in the general population, you may have that, but this study, yeah, how they are contracted, there could be congenital, from mother to child. When you eat properly cooked meat, you're introduced to the oocyst, which can establish itself and be reactivated when you're immune compromised, especially for immune compromised. Most persons actually may show levels of toxo infection, either to IgG or IgM antibodies, but they are healthy persons because it hasn't been reactivated. They are healthy carriers. But once the immune system goes down, it goes further to affect and, of course, have Toxoplasma encephalitis and all that. Thank you.
Okay, thank you, presenter. I want to ask, apart from the ELISA method, was there any other method you used?
There are we could move on to molecular methods, which is more expensive, but I stopped at ELISA for this work.
No microscopic and...
Well, the truth is, for toxo, it's very tricky with microscopy. It's, I'm not saying it can't be diagnosed microscopically, but if you read up literature and from experience and practice, you discover that it's not that easy to diagnose microscopically. In fact, for some persons, they consider it time wasting and labor, to go microscopic. So rather, you look at immuno methods for detection. Yes.
Okay, my worry is you had such a high prevalence among the psychiatric patients, inmates in the hospital ward, isn't it?
I actually worked with both in and out patients.
Did you divide them into groups so as to, because we are worried. How was it with those? You got them from the streets?
No, those attending clinic but not inmates. They are normal enough to return back home, though they are psychiatric patients in a way.
What was the prevalence among those ones compared to the inmates?
It was higher among those within the hospital, actually.
So
Yes.
here now is pointing to the environment. Pointing to the environment. You see? That underscores the question she was asking.
Okay.
Well, there's not much we can do here than to clap for you and then in your study.
For that study, thank you.
Yes. See how you can really look at the environment and see how this thing is transmitted.
Okay, Prof.
Thank you very much.
Thank you very much, Prof.
Who is the next, please? How many people are left on the front seat? Please, we want to feel encouraged that we are moving on. So let all those who are yet to present really come to the front seat. Let those who have presented move so that as we look at you, we know that we're making progress. We know how many people are left.
Sorry, Felicitas, are you here? Yeah.
Sorry, please, for those listening online, there's one Mr. Christopher. People are complaining that your audio is disturbing the live stream. Please, if you are watching, can you kindly mute your mic, please? Mr. Christopher Energy. Thank you.
Akpet. Okay, please, can you come over, please? 3, yeah. But Eze is around too. Eze. So Akpet, Ms. Akpet will be speaking on the knowledge, attitude, and practice of cough etiquette and respiratory hygiene among undergraduate students in the University of Calabar. 39.
Good afternoon, professors, lecturers, students.
Just note that your time is 5 minutes. Try and keep to it. Okay. 5 minutes.
Okay. Good afternoon, professors, lecturers, students, and my other audience. My name is Beverly Ingwe, a final year medical student, University of Calabar. I'll be presenting on behalf of my co-authors. My presentation is knowledge, attitude, and practice of cough etiquette and respiratory hygiene amongst undergraduates in the University of Calabar, Cross River State, Nigeria. Introduction. Cough etiquette and respiratory hygiene are health measures carried out by the public to ensure containment of respiratory infection. This infection places a significant burden on health worldwide. In Nigeria, studies have reported varying prevalence rates of respiratory infection. Ilorin recorded 36%, Ado-Ekiti recorded 87%, especially in low-income population where hygiene practices are suboptimal. Respiratory infections remain one of the leading causes of morbidity and mortality. The World Health Organization reports that lower respiratory tract infection are the 7 biggest killers in upper middle income country and the first in low income country. University students are vulnerable because of their living and learning environment. Most universities, including the University of Calabar, have limited space for the growing student population, inadequate hand washing station, and low awareness on respiratory hygiene. Statements of problem. A study among college adolescents in Nigeria showed that awareness of COVID-19 was high. Preventive practice was low. This gap increases the risk of respiratory infection. At the University of Calabar, lack of tissue disposal points, insufficient hand washing station, and limited health education program weaken awareness to hygiene guidelines. Objective. The general objective was to assess the knowledge, attitude, practice of cough etiquette among undergraduate students of the University of Calabar. Specific objective was to determine the knowledge, to explore attitude, to study practices, and identify the factors influencing these practices. Materials and method. This study was carried out in the University of Calabar. The design was descriptive and cross-sectional. The population was undergraduate students.
Can we just go to the results and conclusion, because your time is up.
Results. Table 1 shows the social demographic characteristics of respondents. When males were higher in number, mean age was 26.5 plus or minus 26.5 plus or minus 5. Table 2 shows the knowledge of cough etiquette and respiratory hygiene was high. 96.43% had good knowledge. Table 3 shows that attitude towards cough etiquette and respiratory hygiene was also high. Practice of cough etiquette and respiratory hygiene showed gap despite high level of knowledge and attitude. Discussion. Acute respiratory infection remained a public concern. Conclusion. Knowledge and attitude towards cough etiquette and respiratory hygiene among undergraduate students of University of Calabar were high. Practices were low. Factors that contributed to this were high cost of hygiene products, limited supply, poor waste disposal facilities. Recommendation: the university should improve access to hygiene material, provide adequate waste disposal facilities, ensure more functional hand washing system to help students translate their good knowledge and attitude into a better hygiene practices. Thank you.
She's on time. Can we appreciate any question on this hygiene so that some other people can come up? We have less than 10 minutes to round up this session so that another session can take off. So please, let's just appreciate her. As we call on Dr. Eze. Eze is going to be one of the officials in the next season. So it's important that he presents now so that he can be available to partake in his own session. So please, let's make welcome for Dr. Eze Adindu. Oh, she didn't know we are done with her. Sorry. Let's make welcome for Dr. Eze Adindu as he mounts the podium. Thank you.
Good afternoon, professors. Good afternoon, my colleagues. My name is Dr. Eze Adindu, a senior lecturer in the Department of Biochemistry, University of Calabar. This afternoon, I'm going to present a work on chemical composition of Rejuvenator energy drink, a local herbal fertility and libido booster. I know a lot of people will be so much interested because this is what makes a man a man. And the second slide, please. Second slide. This is the material we are talking about. Some people call it carburetor cleanser. Some people call it atasa. Some people call it mara. And we are going to look at the composition. The next slide, please. These are the contents. Next slide, please. We know that Chinua Achebe said that once the bed is shaken, the family will be at peace. And that is an absolute truth. Sexual dysfunction is actually a problem. Erectile dysfunction is actually a problem that has bedeviled many families. It has led to various breakdowns in relationship, marriage disputes, and sometimes to death. And then we have also seen that a man who is not actively performing, it is not about having an erection, it's about sustaining that erection for satisfaction of sexual desires. And a man who is not actually performing has a lot of psychological issues. We all know that. And then one day I was just passing along my neighborhood. I saw people gathered. They were buying this product. I said, what is it all about? They said, this product resurrects a dead man. I said, who is a dead man? A man who is experiencing erectile dysfunction. I said, oh, let me check. And I collected one and had a test of it because it is aqueous. And when I reached home, somebody confirmed that I was converted to, in short, somebody confirmed that I was a born again. And I was really a born again because it converted me to 24, 18-year-old boy. And I was so happy. And then, you know, ethnomedicine, you see a lot of people consuming a lot of things without knowing the content. Once they are being branded and say it cures this, cures this. So in this study, if you go to the next slide, go to the next slide. Next slide, please. Fast, we don't have time. Hello. The challenge is sexual dysfunction and infertility. self-help, men and women drink a lot of things in order to see how to revert this particular situation, and the effect that there are a lot of health maladies and sometimes to death. Let's go to the first slide. First slide. No. The objective, you have seen the statement. The next one, please. You have seen the M, you have seen the objectives, you have seen the materials and methods. All methods we are used according to standard procedures. This is the, please go back. Follow me, please. This is the phytochemical screening using GCFID, and from here you can see that resveratrol, which is a major component in phosphodiesterase 5, nitric oxide CGMP pathway, is very high. And because of the level of resveratrol, which is the highest there, it now tries to support that this compound or this substance will actually have a sex enhancing property. And you also see the levels of steroids there. You also see the levels of oxalates. They are all high, even flavonoids. All of them have been implicated in sexual virility. Next slide, please. We also looked at the proximate analysis, and we found out that we have a very high, by the way, we should also expect highest amount of moisture because it is aqueous. And you can see the low amount of ash content, fiber, fat, protein, carbohydrate, which means this is not, doesn't have much food value. It's just the moisture content. Go ahead, the next slide. This is the vitamin content of Rejuvenator. We found out that vitamin C, ascorbic acid, is the highest. We know the roles of ascorbic acid in the body and in the enzyme pathway. We also found out that the vitamin A, retinol, is also very high. But unfortunately, we were expecting that vitamin E, tocopherol, will be high. But unfortunately, it is low, which puts a question mark to the infertility level, infertility property or potential of this particular herbal mixture. Next one. We went ahead to look at the mineral content by assessing the heavy metal. All the metals assessed, both macro and micro, were below the highest tolerable level, which means that it is safe. And then, we also went to look at the label of this particular herbal mixture. We saw a lot of plant products that have been implicated, documented to have sexual enhancing potentials. And then the claim made by the users, because I wish I had the opportunity, I would have brought so that you test and see that the Lord is good. Then we are now going into a further study, which is ongoing, to actually find out the effects of this particular herbal concoction on other biochemical parameters and reproductive sex hormones potentials. So the work is ongoing. Thank you so much.
Well, any questions? Well, yeah, before I continue, I'll just advise that Dr. Eze, maybe you should give them the components so that they can be writing it on the bottle so you can see.
So the material is available. It's for the old and the young.
It's okay. A lot of emotions here. We will need more of the science. Thank you for saying that the study is ongoing. In this study, you would need to also include some known substances so that you can compare substances that are known for these the activities that are giving you, making you so that in subsequent presentation we can see and really get to understand the science. Thank you very much. Please, for the sake of time, allow him. He will come again, so that one or two people can present for us to take a leave. Please. Thank you. All right. Call on the next.
Number Is that Abiji? No. Lillian? Which number is it? Ayam Lillian. Okay, yeah, okay. Sorry, he was supposed to present before you actually. He was not here when she was called. So we're not jumping. Okay. 5 minutes.
Good afternoon, professors, lecturers, and students. My name is Dr. Lillian Yam. I'm here to present on the title, Traditional Birth Attendants' Knowledge and Practice of Third-Stage Labor and Prevention of Vertical Transmission of HIV/AIDS. According to WHO, a traditional birth attendant is a person who assists a mother during birth and who initially acquired her skills by delivering babies herself or through apprenticeship to other traditional birth attendants. Third-stage labor involves placenta delivery. Involving placenta delivery is crucial due to postpartum hemorrhage. Transmission of HIV/AIDS, mother to child, is the most common route of HIV infection among children. Without effective intervention, about 67,500 infants will be infected annually. TBA assists in 60 to 80% of deliveries in Nigeria. Complications during third-stage labor, particularly postpartum hemorrhage, is a leading cause of maternal mortality, affecting about 35.4% of women during birth, and this remains a significant concern in Africa. Despite training programs, third-stage labor management and vertical transmission of HIV/AIDS among TBAs is poorly understood. My objectives are to assess level of knowledge on management of third-stage labor and prevention of HIV/AIDS among TBAs, to assess their level of practice, to determine the utilization of the guidelines, and to identify barriers of vertical transmission prevention. Materials and methods. The study area was Central Senatorial District of Cross River State. The study population were TBA. Study design was cross-sectional study design. Instrument for data collection was interviewers administered questionnaires. SPSS was used to analyze the data. Sampling procedure was snowball sampling procedure was used. My results. Highlights of the socio-demographic characteristics are here. The ages of the TBAs were 51 to 60% was 44.8%. Most of them were married. All of them were females. Their level of education, secondary education, was higher amongst them. Then the level of knowledge. Their level of knowledge, 36.6% had good knowledge, and this was contrasting to SN et al. 2023 and Zonto in their study in Western Nigeria, which said they had 76.4% and 86.4% of good knowledge among TBAs. Their practice level was 15% good practice and 85% poor practice. The frequency of utilization of the mother-to-child transmission prevention guidelines was 81%. Sorry. Out of the 54% that knew about the guidelines, just 29.6% reported always using the guideline. And this did not align with the study done in Nairobi, where 81% of the TBAs adhered to the recommended guidelines. Now, association between the level of knowledge and practice was also assessed, and it was statistically significant.
Time up. Time up.
Okay. Barriers observed were ignorance, lack of compliance from the clients, discussion. The level of education was poor. Okay, conclusion. The study highlights significant gaps in both knowledge and practice among traditional birth attendants in Southern Senatorial District of Cross River State concerning the management of stage labor and the prevention of mother-to-child transmission. Findings also identify barriers to effective practice of management and prevention of HIV/AIDS, mother-to-child prevention of HIV/AIDS, such as ignorance, lack of necessary resources, and lack of compliance from the clients. Thank you.
Good morning, the panel of judges, my professors, lecturers, co-presenters, ladies and gentlemen. I'm a final year medical student presenting knowledge, attitude, and practice towards cervical cancer and cervical cancer screening amongst the staff of College of Health Technology, Calabar. So, and let's begin by the introduction. We say that it's the fourth most common cancer worldwide for women, with 606,000 new cases. And in Nigeria, it's causing 12,000 new cases and 7,000 deaths every year. It is important we had this study because it is projected by 2030 that we'll have 440,000 new cases every year. So the study addresses the gaps in knowledge such in our facilities like College of Health Technology and the low attitude and practice despite good knowledge. So in the general and specific objective, general objective was to determine the knowledge and attitude and practice towards cervical cancer and cervical cancer screening among staff of College of Technology, Calabar, and the specific objective was focused on determining the knowledge, assessing the attitude, to assessing the practice, and to identify the factors influencing the cervical cancer screening. The study setting was, as I said, the College of Health Technology in Calabar. The design was a descriptive cross-sectional study. The sample size was 128, which was adjusted for 10% with the Cochrane formula. The tool we used was an interviewer-administered questionnaire, so as to ensure that every answer that they will not be confused on. And we used an SPSS, and the ethical consideration was taken from the University of Calabar Teaching Hospital Ethics Committee. For the results, we move on to the social demographics. The mean age of respondents was 39.2 plus or minus 10.3 respondents. We discovered that a majority of 100% of them were Christians, and majority of the tribe that answers were 28%. Then we move on to the knowledge of cervical cancer. The overall knowledge was 52.6%. We discovered also in the attitude, the overall was poor. The people that had good was lower than the one that had bad attitude with 45.7%. Then in the practice, it was very low, as 16.4% had actually had good practice, with 78% of the respondents doing it within the 5 years. Then for the factors influencing cervical cancer screening, we discovered two things: the age, and then the knowledge. People who were above 60 years had better practice, and we discovered that with improved knowledge, it was improved. The knowledge of cervical, what does this imply? Knowledge being 52.6 is synonymous with other studies done previously, but the attitude still remains low, with 69.8% of people being neutral to the questions. Then for the practice, we discovered that we are actually, even the Calabar actually higher than previous studies, which had 42.6 only having good practice. Then to conclude, cervical cancer remains a serious health threat in Nigeria, and it's something that we need to take care of because our mothers, sisters, and yes, really our daughters will be affected by the disease. And we start by going to the specific issue by focusing on the leaders, the provost of the College of Technology should organize seminars and to train staff on cervical cancer screening. Non-governmental organizations should be encouraged to create awareness and organize a free and subsidized screening. And then lastly, to the government to ensure that there is a solidified policy on cervical cancer screening. And they should be able to have a great media coverage of this, or to teach everyone of this disease from primary school to universities. Thank you very much. These are my recommendations.
We're able to keep to time. As I'm listening to you, I wonder if the researcher, you being a male, did not affect the study. when you had to investigate cervix of a female Homo sapiens. But it's okay. Thank you. I hope no question for him, isn't it? No, okay. Please, let his friend come and... okay.
Sorry, let me quickly seize this opportunity to talk about cervical cancer. It's not a question, please. It is something I want to talk to all the females here and also the males here also. Please, we are having very low, turnout for cervical cancer screening. We know that prevention is primary, secondary, tertiary, and we prefer primary, please. Cervical cancer screening is for all women of childbearing age. Actually, it should start once a woman has become sexually active, about 3 years after that. And we know that our young girls now are sexually active much earlier. And it should continue till you are at least 65 years. After that, you may decide to stop. It is done every 3 years. Please, University of Calabar Teaching Hospital, we are still having a high rate of cervical cancer, and which is very, a lot of them come at the very late stage where we just do palliative treatment. I want to please recommend that every female of childbearing age that is sexually active especially should be doing her pap smear every 3 years. The cost is actually 3,000. A lot of prices have been increased in the teaching hospital, but our department has fought for that to remain as low as 3,000. And if you are on NHIS or NHIA, it's even done free. It's captured by NHIA. Please, all the women should please do it, and even all the husbands, please take the message home to your wives, to your sisters, even your mothers, please. Everybody should do it because we are still having a lot of cervical cancer. That is one of the primary screening methods for cervical cancer. Thank you very much.
Thank you.
Okay. Good afternoon. Ajunwa will be speaking on factors associated with male contraceptive use among healthcare workers in the University of Calabar. Male care.
Yes, good afternoon, professors and my audience. I'm presenting a topic on factors associated with the use of male contraceptive among healthcare workers at the University of Calabar. I'm presenting on behalf of my co-authors. Presenting with this outline on introduction, due to an alarming world population growth and its health impact, a lot of research has been channeled into developing contraceptives and family plan methods. However, most of these studies were conducted in women because of the society erroneous belief that men shouldn't be involved in contraception, that is a woman's burden. This has led to an alarming rise in unintended pregnancies with associated maternal morbidity and mortality, despite more women using contraceptives than in the past. Hence, it's important to determine which factors affect male contraceptive use with a goal of providing enough education. The statement of problem the limited male contraceptive options, or willingness to use male contraceptives, and paucity on the factors associated with the use of male contraception. My general objective of the study was to identify the factors associated with the use of male contraceptives in the study population. Specific objectives: determine the knowledge, the prevalence, the types of male contraceptive method used, and identify the factors influencing the use of male contraceptives. The study was conducted in the University of Calabar Teaching Hospital using a descriptive cross-sectional study. The study population involved male healthcare workers. The sample size was 180, determined using the Cochrane formula. The sampling method employed was a descriptive cross-sectional study and analyzed using SPSS. And the research was conducted based on the ethical standards set by the Health and Research and Ethical Committee. For my results, the social demographics from table 1, we see that a total of 180 respondents were recruited. The mean age was 35 plus or minus 8.3. Figure 1 showed that the level of awareness of male contraceptives was 97.78%, the knowledge 71%, that 71% had good knowledge. Figure 3, the prevalence of use was 75%, and the most common type of male contraceptive use was condoms. Vasectomy was the least used. For the factors that was significantly associated with the use of male contraceptives, we have the age, religion, and contraceptive awareness. For discussion, awareness of male contraceptive methods from our study was 97.78%, congruent with a study conducted in Oyo that showed that the awareness was 78%, and this could be to the fact that healthcare workers and other platforms increased awareness of male contraception. The knowledge in our study was 71%. However, there is paucity of literature, so we couldn't draft a comparison between knowledge in our study with existing research. Then the prevalence of use in our study was 75%, less than 88% from a study in Picro et al. The factors have already been stated in the results section. So in conclusion, our study achieved its aim. It identifies significant associations between age, religion, and awareness level with contraceptive use. So the findings serve as a guide to making recommendations, and we make these recommendations to healthcare workers. They should promote male contraceptive methods and encourage their colleagues to visit the family planning unit. To the hospital administrators, they should provide training and programs and allocate resources for male contraceptive usage. Then to researchers, they should explore the barriers to male contraceptives. There are some gaps identified by our study which could build a foundation to further research. By implementing these recommendations, we can improve our knowledge, attitude, and practice of male contraceptives among healthcare workers and the community. So these are my references, and thank you so much for listening.
Thank you. For a change, we are hearing male. Thank you. This brings us to the end of this. Is there any question? Male, now please be jealous. Ask questions. Okay, none. Thank you very much.
Thank you, sir.
Anybody left? Okay, thank you very much. You have been a very good audience. The Professor Tango, I don't know if I can suggest there should be an award for the participants, those who come in, stay through to the end and alive, like our colleagues here and Dr. Young and the rest, quite very, very active and attentive, listening to all the presentation, criticizing, commenting. So I really enjoyed this session because of this that you have done. Thank you very much. May I also inform us gladly that we were able to take 15 presentations between this. Thank you very much. I bet we have overshot by about 1 hour. Okay, just 20 minutes. That's good. But this session is not over until we go to the poster presentation section out there, and I'm told it will take about, that session is allotted 30 minutes. So officially, we'll come to the end of this session after 30 minutes of your interaction at the poster area. Thank you very much. I want to say a big thank you to my colleagues, Professor Bob Ngbeje and Dr. Mfoniso. It's been nice working with you. God bless you.
Please note that the poster viewing is just 20 minutes. And after that, we come back for the afternoon session. Please, just 20 minutes. And we are back here.
working on my system. Yeah, because that adapter that is added into that other system could be the reason why this is not transmitting the signals. Because normally someone is supposed to stand here and control your slide. That's how it should be. Because the worst thing is that it's not seen. So he doesn't know when you are done with the discussion or not.
Okay, please, can we come in so we can start the afternoon session? Please. Can we come in so we can begin the afternoon session, please? Can we all come in so we can start the afternoon session, please? Let's come in so we can start the afternoon session, please. Come in so we start this next session so we don't stay too late. Please, I want to call those who will moderate this session up. I want to believe that when we start, others will join. Those of you at the back, we have begged you several times, although I know the fans are the rare, so maybe that's what is responsible for most of us clustering around the back. This to chair this session is we have two distinguished professors of biochemistry, Professor Friday E. Ubo and Professor Richard Upanukong. Can we put our hands together for them as they come to the high table? You know, when I did it, it's after I finished and answered, oh, it was like a biochemistry affair. I didn't even know. So, I didn't even know it was. Look at you. It's when I was collating the list. I was there are so many about. Anyway, you can understand with me. Yes. So, exactly. So, another distinguished bosom friend in the team is Dr. Boniface Ago. Let's put our hands together for him as he joins them in the high table. We also have another biochemist in the team, Dr. Eze Adindu, to join them in the high table, right there on the high table. So let's clap for them quickly as I hand over the microphone to them to begin this session. I know this other group of people, they will be snappy because we have to leave here early enough. Thank you so much. Here is your list.
Right, thank you very much, sir. Already we are almost how many minutes behind schedule? Almost getting to 1 hour. We were supposed to begin by 2 p.m. So we try as much as possible. I don't know how many people here are presenting. So please, we are going to read the names of those that are supposed to present here. If your name is in the list, you will come to the front so that we know how many people we are actually attending to.
Thank you very much. First in the list is John Bull Martin Uket. Yes. You are already here. Thank you, sir. Etefia. Okay, please, thank you. Come closer. We have Mkanem N.E. Please, is he in the hall? I think we can mark the ones that are not in the hall. Obianwu. Who is Obianwu? Please come closer. Okay. Kalio. Umon AA. Thank you. Ekemeni. Jeremiah. Okay, come closer, please. Wasam Elemi. Are you Elemi, sir? Elemi. Yolo BS. Okay, thank you. Come closer, sir. See you. Come closer, sir. Afion Akpandem. Please come closer. Diaminio. Oyeni Tia. Come closer. Chidibere. Chidibere. Ideka Abasi. Maybe he has presented. Josephine E. Ebu. Come closer. Okay. So.
All right, we are going to start straight ahead. Please, each presenter, you have just 5 minutes. 5 minutes. Abridge your introduction. The major thing will be the topic, why you felt that that topic is researchable, and what you discovered at the end of your research. I think that's 5 minutes should be able to cover that. Thank you.
We will give a warning signal when it is 4 minutes. That will be enough for us. So, we are calling on the first presenter for this section, John Bull Martin. Okay, please take the stage.
Good afternoon, members of the panel and co-presenters, as well as staff and students. I am here to present a paper on the effect of administration of alligator pepper, extract, and gingerol on calcium carbonate motor coordination impaired mice. That's my table of content. Please move to the next slide. It's not responding. Motor coordination is associated with Parkinsonism, and Parkinson is one of the most neurodegenerative disorders whose pathogenesis is not well established. And gingerol is been implicated in coordination of motor to improve motor coordination, and alligator pepper have been found in a laboratory to contain 6-gingerol. Recently in our laboratory, a study shows that there was improvement in motor coordination in apparently normal mice treated with alligator pepper. That we attributed that to be the presence of gingerol in alligator pepper. And that, however, whether the administration of alligator pepper that contains 6-gingerol will improve motor coordination in mice with impaired motor coordination has not been previously asserted. Therefore, this research was to study the effects of administration of alligator pepper extract and gingerol on calcium carbonate motor coordination in impaired mice. Statement of the problem. Statistics shows that the prevalence of Parkinson's disease has doubled in the past 25 years. Global estimate in 2019 shows over 8.5 million individuals with Parkinson's, an increase of 81% since 2000, and has caused 329,000 deaths. Then recent modeling suggests that the number will increase significantly, up to 25 million by 2050. The aim and objective of this study. The aim of this study was to investigate the effect of administration of alligator pepper extract and gingerol on calcium carbonate motor coordination impaired mice. The objectives of this study include to investigate the effects of the alligator pepper on motor coordination, and also to investigate the effect of 6-gingerol supplement on motor coordination in mice. The materials we use 30 CD1 mice, and we grouped them into 6. The group 1 was served as control, and the group 2 served as alligator pepper extract only, and group 3 received 6-gingerol supplement orally, and group 4 was treated with alligator pepper extract plus 1% calcium carbonate diet, and group 5 were treated with 6-gingerol supplement and also with calcium carbonate diet, and group 6 received calcium carbonate diet only. And that the mice were treated with alligator pepper and gingerol as well as calcium carbonate for 30 days, and that the animal models were tested for motor coordination using the beam walking apparatus. This result here, the first result, is indicating the line crossing made by the animals. We use it to assess motor coordination as one of the symptoms that is always presented in Parkinson's disease. The next slide, please. The next slide is indicating the reversers. We use reversers to assess the ability of an animal to assess fine motor coordination, which is one of the component factors that is affected in Parkinson's cases. And then the last one is the foot slip. Sorry, foot slips. The foot slips, we use them to see if the animal can gain stability on the beam walking apparatus to also assess the motor coordination function. I could not present the last parameter that is always added, associated in this study, which is latency to fall. Because in all the 6 groups, we could not have any animal that actually falls. So there was no need for including such data in this study. Discussion, motor coordination was impaired in animals treated with calcium carbonate only compared with control and other experimental groups. From the results, and that the result also showed that there was no significant difference between the alligator pepper group compared to the cisgingerol supplement. Next slide. Conclusion. Administration of alligator pepper and gingerol supplement improve motor coordination in calcium carbonate impaired motor coordination in mice. The motor function enhancement observed may be attributed to gingerol that is present in alligator pepper. The next slide. This is my recommendation. I recommend that most studies should be carried on alligator pepper to establish the potential neural pathway, because dopamine that is always attributed in Parkinson alligator pepper does not have a precursor for dopamine. So there must be another thing that is responsible for this enhancement that is observed as improved motor coordination. Thank you. And my references are the last there.
Thank you very much. Thank you, Mr. Presenter. Alligator pepper and motor coordination. Is there any question? Any question? We'll take just one. Right, in the absence of any question, the presenter has made us to understand that if anybody is having any impaired motor coordination, alligator pepper can do the magic. So let's put our hands together for him. Thank you, sir.
Thank you, John Boo. We are going to the next presenter, Itefia. Please, you take the stage.
Good afternoon, distinguished professors, ladies and gentlemen. My name is Dr. Itefia, and it's a privilege to present our research on the topic genetic diversity of Plasmodium falciparum, with emphasis on mesosurface protein 1 and KELK13 in Calabar, Nigeria. Malaria is among the leading global public health challenges with high morbidity and mortality. And unfortunately, Nigeria is one of the countries with the highest burden of the disease, with approximately 27% global cases, according to the WHO. MSP1 plays a key role in the parasite invasion into the red blood cell, and it is highly polymorphic. Genetic diversity of P. falciparum impacts vaccine design and drug resistance. There is also a growing trend of artemisinin resistance, and this has been attributed to mutations in K13. However, in spite of these challenges, limited molecular data exists for Calabar region based on literature search. Hence, to assess the genetic diversity of Plasmodium falciparum using MSP1 and K13 markers in Calabar, the objectives were to determine the allele frequency of MSP1 genotypes and also to detect K13 mutation linked to artemisinin resistance. The study design was a cross-sectional study of 262 febrile subjects from the age of 9 years and above who were referred by the physicians in the UCTH and the General Hospital Calabar. Ethical approval were obtained from the UCTH Health Research Ethics Committee and the Cross River State Health Research Ethics Committee. Samples that were collected were both the peripheral and the venous blood samples. The peripheral blood sample was used for microscopy, while the venous blood samples were used for molecular analysis. For the molecular analysis, DNA extraction was carried out, followed by PCR amplification, and then finally sequencing. The sequenced genes were analyzed using bioinformatic analysis procedures. Key findings. The prevalence of malaria parasite infection in the study was 19.1% in microscopy and 38.2% in PCR. In terms of sensitivity and specificity, because PCR in this case was considered as a gold standard. So microscopy was compared in relation to PCR. Sensitivity was 100% and specificity was 52.4%. Most of the infections were polyclonal with multiplicity of infection of 1.72% and heterozygosity of 0.57%. The rate of frequency of MSP1 in the study was 38.2%, and K1 variant of MSP1 was the most prevalent. In terms of mutation of K13, 23.1% of K13 were mutated, and out of the mutated genes, 33.3% had a 4-point mutation, while 66.7% had a 1-point mutation. Conclusion. The prevalence of Plasmodium falciparum in Calabar was 9.1%, and that of PCR was 38.2%. This shows diagnostic gaps between the two techniques. This study has established that there are genetic variations of MSP1 among people of age from 9 years and above in Calabar. High genetic diversity in Plasmodium falciparum indicates sustained transmission. From literature research, the study of K13 is the first in the study area. It has also been shown that in this study there is K13 mutation and this highlights the need for continuous surveillance of drug resistance. Effective malaria control requires strengthened diagnostic capacity, regular training of microscopists, and broaden public health awareness. Thank you for your attention.
Thank you very much, sir. Is there any question? Is there any question? Nobody has any question? There is one hand there. All right.
All right, thank you, sir, for the beautiful presentation. I am Dr. Oda Ikaiti Sunday, Department of Pharmacology. Please, I want to know where you conducted your genetic analysis in Calabar. Thank you.
Thank you so much. The genetic analysis was conducted at Niger Delta University laboratory with Professor Taffen in Bayelsa.
All right. Well, your question is answered. So if you want to do that, you go to Bayelsa State and I meet him for more information. Let's applaud him for the presentation. The next presenter.
Please, the next presenter is Obianwu SN. Please, let's go in that order. While Umon AA should be ready. You are using the same system. Okay, please. Mpane, please, come on.
Good afternoon, everyone. Permit me to stand on the already existing protocol. My name is Daniel Abraham from the Department of Community Medicine. I'm a final year medical student. And my presentation today will be centered on the influence of social media use on the mental health among undergraduates in the University of Cross River State, Calabar. This presentation would go as follows: introduction, stroke background, the statements of problem, aims and objective, materials and method used, results, discussion, stroke implication, and conclusion. The substantial growth of social media networking sites has fundamentally influenced the way humans interact, communicate, and share knowledge. Social media platforms such as WhatsApp, Twitter, Facebook, Instagram, Snapchat, TikTok has become integral part of our daily life, particularly among young students, including university students. The relationship between the use of social media and the mental health of undergraduate students have created immense concern in the mind of clinicians and curious minds like us due to the increase in the rates of mental health indicators such as mood changes, stress or anxiety disorders, and low self-image. There have been studies that have been carried out by numerous associations and groups which have agreed with the above work, and notably post-NG 2019 linked the increasing rates of suicide among Nigerian youths to social media influence, particularly negative online interactions and cyberbullying. Studies have also shown that many undergraduates actively engage with social media, but the extent of this impact has not been studied, and hence the reason for our study. So our study aims to explore the influence of social media use on the mental health of students in the University of Cross River State, Calabar. Now the objective of our study was to examine the influence of social media use on the mental health of undergraduates of the University of Cross River State. Our specific objectives were to assess the frequency of social media use among undergraduates at the University of Cross River State, to assess the time spent daily on social media by these undergraduates, to identify common mental health issues linked to excessive social media use among the students, and to examine the relationship between the type of social media platform use and the student's mental well-being. Our method and methodology. The study setting was the University of Cross River State, Calabar Unicross. Study design was descriptive cross-sectional study. Our study population were students of the above institution from the 6 faculties and 26 departments of Unicross. Our inclusion criteria were all consenting students currently enrolled in the university, and we excluded students that were sick and absent at the time of data collection and students with obvious mental challenge. Worthy of note that we got an ethical clearance from the University of Calabar Health Ethical Clearance Committee. Our sample size was calculated thus using the Concran formula, and we used a multi-stage sampling technique to carry out this study. The result of this study was analyzed by the International Business Management Statistical Package for the Social Science version 26.0. Our outcome variables were mental health indicators such as sleep effects, mood effects, anxiety effects, addictive effects, and self-esteem effects. The explanatory variables was the use of social media. Worthy of note, other outcome variables that could also affect the mental health, such as academic stress, family background, or financial challenges, were not deeply examined. The result of the study. Our result shows that 80.4% of the students use social media several times daily, which aligns with the national and global trend of the increased rate of social media use among students. It also shows high engagement, that high engagement suggests deep integration into our daily life. We also found out that 33.5% were moderate users, while 29.7% were extremely heavy users. The frequency often predicts longer daily usage due to habit loop and algorithm. We saw that sleep effects had the highest of the mental health indicators. And also, using the chi-square test of statistically significant, there was no significant relationship between the association of the platform use and the well-being, the mental well-being.
Give us your conclusion.
In conclusion, our study underscored the need for targeted awareness campaign and preventive intervention to promote healthier social media engagement among students. Thank you.
Thank you very much. Social media. Is any question? Any question for you? No question. Okay, there's a hand. All right. Can you come closer, please?
Okay, thank you for that wonderful presentation. I am Dr. Link Spore. I'm concerned about where you obtain your ethical approval, because I know that where you did your work, you were supposed to obtain it from Ministry of Health.
All right, thank you very much, sir. This study was carried out as our final year project work, and our ethical committee was the University of Calabar Health Ethical Research Committee. That's where we got our approval. Thank you.
All right, thank you very much. So what do you advocate now? They should reduce the rate of the usage of social media?
Sir?
What are you advocating at the end of your study? Should we reduce the rate of the use of social media, or they should increase?
No, sir. It promotes healthy habits, both on the users and also on policy making, the policy makers.
Right, let's appreciate him. The work he has tried.
Thank you, Mr. Presenter. We call on the next presenter, Obianwu. Thank you.
Good afternoon, professors, doctors, my lecturers, and my fellow students. My name is Odibu Gladys Agbo. I'm representing the Department of Community Medicine. My topic is knowledge and attitude towards HIV pre-exposure prophylaxis among healthcare workers in University of Calabar Teaching Hospital, Calabar, Nigeria. The slide? Yes. Introduction. HIV, human immunodeficiency virus, is a health burden globally, with records of about 39 million people living with HIV worldwide, and over 1.3 million new infections are recorded annually. Regionally, sub-Saharan Africa has over 2/3 of this global HIV burden, accounting for about 26 million persons living with HIV. In Nigeria, there is a 1.4% prevalence of HIV among persons aged 15 to 49 years, and approximately 1.8 million people are living with HIV. Pre-exposure prophylaxis PrEP are medications taken before exposure to HIV by HIV-negative individuals to reduce their risk of getting HIV. Example, tenofovir and emtricitabine. In the University of Calabar Teaching Hospital, limited studies were carried out to assess the knowledge, attitudes, and willingness of the use of PrEP among healthcare workers. This study therefore addresses the gap and explores influencing factors to improve staff training and use. Statement of problem. Despite multiple HIV prevention strategies, the rate of infection remains high. Healthcare workers have an increased risk of infection through contact with infected blood and body fluids. PrEP use and prescription among healthcare workers is poor, despite having proven to be about 98% effective. No previous data on assessing the knowledge, attitude, and willingness to use and prescribe PrEP has been recorded in UCTH. Therefore, addressing this gap will improve occupational safety and HIV prevention outcomes. The aim and objectives. The study aimed to investigate the knowledge, attitudes towards pre-exposure prophylaxis among healthcare workers in University of Calabar and the specific objectives were to assess the level of awareness, assess health workers' knowledge, attitudes, and factors influencing healthcare workers' willingness to use and prescribe PrEP, materials and methods. It's a cross-sectional descriptive study carried out in the University of Calabar Teaching Hospital. The study population were healthcare workers, which included doctors, nurses, lab scientists, and health assistants. The sample size was 410, and the sampling technique used was a multi-stage probability sampling method. The data collection tool used was pre-tested self-administered questionnaire and analyzed, cleaned using Microsoft Excel version 210, and analyzed using IBM SPSS. Ethical clearance was obtained from the Ethical Committee Board of University of Calabar Teaching Hospital. Informed consents and confidentiality were adhered. The results showed that the mean age was between 36 to 45 age group, mostly females, tertiary level of education, mostly nurses, years of experience, about 9.8%, more than 20 years of experience. So in conclusion, awareness and attitudes towards pre-exposure prophylaxis are generally high. The knowledge is moderate with key gaps in eligibility and regimen. Willingness influenced by age, profession, years of experience, income, and education. Training, supportive policies, and accessible resources can improve uptake. Thank you very much.
Thank you very much, Freddy. Yes, is there any question, any concern? Can see one hand far behind. Can you come up, please?
Thank you very much for that presentation. I'm Ephraim Onanawu. I just want to ask some questions here. What measures are the health workers taking to protect themselves and from HIV exposure? And what protocols are in place for post-exposure prophylaxis? Thank you.
Okay, so the first measure I want to emphasize on, which is my topic, is to advise healthcare workers to use pre-exposure prophylaxis as a first measure in preventing HIV. There are other measures taken by healthcare workers to prevent HIV, which includes the use of personal protective equipment, like gloves and the personal protective equipment, like the overalls, the aprons, your gloves, and your boots, the boots you wear to prevent yourself from needle prick injuries whenever a needle falls down. Then secondly, the measures for post-exposure prophylaxis. Well, when exposed to HIV, you are required to take your post-exposure prophylaxis medications within 72 hours of exposure, as well as take it for 28 days. But then, we are emphasizing on pre-exposure prophylaxis because pre-exposure prophylaxis prevents this HIV replication within your cells. But post-exposure prophylaxis, it takes time. You need to take the drugs for 28 days after taking it within the first 72 hours. And you are not still sure or ensured that it will still prevent HIV infection. Thank you very much.
Thank you very much. Thank you. Let me find out how many health workers are here. Or if so, how are they going to get this information? Right. Thank you very much. Let's appreciate her.
Thank you. Please, we will call the next presenter, Kalio IL, while Umo AA should be ready. Is Kalio ready? Umo is ready. Please come up.
Good afternoon, everybody. My name is Umar Anye Kanabasi. I'll be presenting the topic Assessment of Patient Satisfaction with Quality of Care and Associated Factors among attendees of medical outpatient departments in a tertiary health facility in Calabar, Cross River State, South Nigeria. This was done as a final year project in the Department of Community Medicine. For my outline, I'll first talk about the introduction, our methodology, our results, discussion, conclusions, and we'll give a slide on our references. For the introduction, quality of care is defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. We're basically trying to determine how satisfied patients are with the services they are getting. And the teaching, despite frameworks like Servicom, patients complain persist at University of Calabar Teaching Hospital, especially about excessive waiting times and staff attitude. Meanwhile, studies have revealed that clients with high level of satisfaction are more regular with their appointments and they adhere to the levels of treatment, which is exactly what we want as health professionals. However, there was a lack of structured feedback mechanism on the satisfaction in University of Calabar Teaching Hospital, especially at the medical outpatient department, which is why we did this study. For the aims and objectives, we want to assess client satisfaction with quality of care and its associated factors at MOPD, University of Calabar Teaching Hospital. We want to assess the satisfaction with the quality of care in general. We want to assess satisfaction across thematic areas, and we want to find out the factors associated with the client satisfaction. For our methodology, our materials and method, it was a facility-based descriptive cross-sectional study. It was done, setting was at medical outpatient department. Sample size was 291, determined with the appropriate formula. For the population, patients greater than 18, male and female, systematic random sampling was done, and exit interviews, after they were done speaking with the doctor, was interviewed via a pre-tested interviewer and an administered questionnaire. Analysis was done with IBM SPSS version 27. For eligibility criteria, only patients greater than 18 that consented. Exclusion criteria was critically ill or mentally unstable patients. We used a structured questionnaire that was adapted from the WHO PSQ3. For ethical consideration, ethical approval was obtained from Research and Ethical Committee of University of Calabar Teaching Hospital before data collection. For our results, for social demographics, we found out that there was a mean age of 46, and the majority, 27%, were between 45 to 55 years, 67% female, marital status, 61% were married, 70% had tertiary education, and overall income was less than 150,000, with the majority, 56%, earning it. For level of satisfaction, we found out that only 30% of respondents were actually satisfied with the quality of service rendered at UCTA, which is quite alarming. On satisfaction for domain, waiting time and accessibility were the major complaints that patients had. We also discovered that there was great dissatisfaction with content of health stock, coming in at 34% satisfaction. On bivariate analysis, the two significant factors we saw were marital status and level of education, and the rest were not so satisfied. As for discussion and conclusion, low satisfaction aligned with previous studies. We also discovered that majority of dissatisfaction was on accessibility and waiting time, and we strongly believe that the hospital authority should do all they can, collaborating with Department of Internal Medicine, to ensure that waiting time can be reduced and accessibility could be improved for health needs across the state. Thank you very much.
Thank you very much, my brother. Is there any question for him? There is a hand here.
Thank you for a very well articulated presentation. But I want to take you back to your work I am believing this work is for publication. There is need to get into the literature. There is need to go back to the literature because the ethics of paper publication must be implied. Your referencing style is not coherent, and that when you are doing a term, you should go back to ensure that you utilize the term. And then the next thing is, I want to ask you, why did you use the statistical tool you use for your data analysis? Why did you choose that statistical tool for your data analysis?
Thank you very much, sir. Thank you for the corrections, which were well noted. For the statistical tool, this is because it's a modified version of a standard. WHO released this PSQ questionnaire, and this questionnaire itself is used for assessing patient health care. It's like a generalized standard. So we modified it to our educational or to our institution, which is what we end up using.
What? The statistical method, the statistical tool. Which one did you use? That's the question. What did you use?
Yes. SPSS. Is it for data analysis? Oh, okay, sir.
He's asking why did you choose that?
Yes, sir. This is why I use IBSS. SPSS is what I'm familiar with, and it's what we encourage at the department to use as well during the course of our.
Well, I'm so happy that you did this type of work, because if you have been to teaching hospital, sometimes you will be frustrated. But the problem, just like the chairman, Professor Obo, asked, how many health personnel are here? Do you have any other opportunity of presenting this, the outcome of this research, to doctors and health workers? Is there any avenue where you can be called upon to present this, the outcome of this research, so that they will know? Because when you go there, you even see students you taught, the way they look at you, the way they behave, they see themselves as if they are superhuman beings because they studied medicine. At the end of the day, you go home frustrated. Very frustrated. So please, if there is an avenue where you can present this output, it will make so much sense. So they will know that the patients, the people they are serving, are not satisfied.
Go back to your supervisor for the sake of publishing. Statistical tools that are used for data analysis is dependent on the number of groups you use. So if this is not fitting into a group, it will not be accepted by some papers. Is that okay? So go back to him. Tell him, you guys should take a critical look at that, and then go for test of hypothesis and see if that is also good to be continued with. Thank you.
Right. Thank you very much, Mr. Presenter. Let's appreciate him. At least he has tried. So you have to go and all the rough edges, make sure you go and smoothen them. The next presenter, Dr. Ayo.
Good afternoon, Chairman of the panel. I appreciate this opportunity you've given me to make this presentation, and I don't take it for granted because I wasn't listed. Okay, I'm presenting on the prevalence of drug-resistant tuberculosis and HIV co-infection among internally displaced persons in Bakassi, Cross River State. So the aim of this study, okay, let me start by way of introduction. Tuberculosis is a chronic airborne infectious disease caused by the Bacillus mycobacterium tuberculosis. And it is ranked among the 10 highest or top causes of death globally. In fact, it is ranked second after COVID. It is one of the diseases that makes Nigeria to be ranked among the 30 high TB burden countries. And the situation is bad in Nigeria because of non-compliance and non-detection of cases. So the aim of this study is to, or was to determine the prevalence of rifampicin resistant TB and HIV co-infection among the internally displaced persons. These are people who are returnees from Cameroon, and Bakassi local government area, as we know the history, was ceased to be part of Cameroon. So all those from Bakassi were now displaced, and so they have to create a place as an emergency situation for them in Ikan. So their situation, their living condition is likened to that of refugees because so many of them were returned and there was no place for them. So they have crowded living conditions that is not even, the social amenities are not available. And this situation makes room for disease spread in their living quarters. Okay, so the materials and methods, the study was a community-based cross-sectional study in Ikan, where we now know as Bakassi local government area. The subjects were HIV positive and HIV negative individuals aged between 15 years and above with active pulmonary TB symptoms and those on ART who gave consent. A total of 244 subjects were enrolled in the study. Ethical approval was obtained from the Cross River State Ministry of Health Research Ethics Committee. And before anything was collected from the subjects, informed consent was obtained. Questionnaires were also administered to obtain vital information on social demographic characteristics. Blood samples were collected from the patient. Sputum samples were also collected. Now for blood sample, the national HIV algorithm for Nigeria was used to test the samples. And then GeneXpert MTB RIF assay was used for TB detection. Rifampicin resistance was also tested for after 2 months of administering the TB regimen. The study was for 6 months. At the first contact, the patients were administered TB drugs, and by month 2 of follow-up, samples were collected and tested for resistance for rifampicin. The statistical analysis, SPSS version 22 was used, and data presented with statistical significance set at 0.05. Now, the results, we have, the first one is the distribution of HIV by social demographic characteristics of subjects. Marital status, age, occupation, educational level were all measured, and statistically, occupation and marital status seem to be significant. For TB also, age was the significant factor. And for the prevalence, can I have that chart? The prevalence of TB only was 17.6%. Prevalence of HIV only was 27.5%. and the co-infection prevalence was 7.4%. Now there were factors that were the factors that predisposed the subjects to TB, HIV, and the co-infection. The first one was apparent malnutrition, or the nutritional status. And we saw that malnutrition was a major factor because the subjects did not feed well. And so that ranked very high there, significant. Economic status too, because they came back with virtually nothing. They didn't have the means to live well. So economic status also ranked high. Then lifestyle, smoking, and all the alcohol use, and then overcrowding in their quarters. These were all factors that predisposed them to infection. So in conclusion, the results of this study recorded a very high prevalence rate for TB, 17.6%, for HIV, 27.5%, and the prevalence for co-infection, TB and HIV, 7.4%. The study also recorded prevalence for rifampicin resistance at 0.41%. So that was heartwarming because it wasn't so high. And the age group that was most affected was 30 to 44 years age bracket. And the factors are malnutrition, alcohol use, crowded environments, poor economic status. These were the factors that predisposed subjects to infection. Also, non-compliance to TB treatment. The recommendations are there that the government needs to focus attention on this group of people because there's so much going on there and they are neglected. So they have to provide the social amenities for them to be able to curb this spread of HIV. These are two serious infections, and with that spreading, it could be a public health emergency. All right, those are the highlights that the prevalence of rifampicin resistant tuberculosis detected through GeneXpert among the study subjects was 0.41%. Thank you very much.
Thank you very much. Thank you very much. IDP. Is there any concern, any question? Okay, let's take the one closer here first.
Thank you for a I want to get clarity. Is the resistance, is it based on the receptors or the people staying away from the rifampicin? Which one? Is it receptor resistant to the drug, or the people are staying away from the use of rifampicin?
Rifampicin is one of the drugs, one of the key drugs in TB treatment. And for TB treatment, it's a regimen, it's a group of drugs that are administered at the same time, isoniazid. So it needs monitored compliance so that resistance does not happen. But what was found out was that the individuals, because of so many things they complained of, were not adhering to the treatment regimen. So it is actually because of non-compliance that can lead to this rifampicin resistance. But fortunately, in this study, the resistance rate was not so high. A number of people responded to the treatment regimen, but just 0.41, and that resistance was due to non-compliance from the study.
the efficacy.
Yes, that's why the risk factors, non-compliance is stated, lifestyle, non-compliance. So it's not, the drug is effective, but due to human factor, this resistance is happening. That's
It's okay. That is to say, so that the patients
you know,
refuse
because
to take
if you refuse, if you don't take it according to the regimen, the dosage, then the microorganisms will develop resistance genes. But what is causing this in the first place is non-compliance, leading to the microbes becoming resistant. When we talk about resistance, it is a microorganism that resists the drug, but there are factors that lead to this. I hope it's understood.
There was a hand before you are on. You want to add to what she's saying? Okay. Let's hear what she want to add. Resistance. But don't bring pharmacology. It's not pharmacology.
No, pharmacology is going to be the bridge between physiology and
Go ahead.
MLS. Okay, for microbe drug resistance is basically due to the microorganism genetic mechanism. So when the patients aren't compliant, the leftover microbes develop genetic materials that can resist the activities of those drugs. It can be in the form of enzymes. It can be in the form of pumps, transporters. It's very multifactorial. So, sir, if you want more, we invite you to pharmacology.
Thank you very much. That if you refuse to take your drugs, by the time you start taking, all the microorganisms must have developed resistance. So take your medication judiciously. Yes?
Thank you, Prof. Thank you, Doctor, for that wonderful presentation. I am truly troubled because recently we cannot actually identify those with TBs and HIV with mere seeing them. So that is where my concern is. So I'm asking, what are the current status of TB treatment outcomes in settings with HIV, with HIV co-infections, and how can we integrate the care appearance with solving these problems? Thank you.
Thank you very much. TB and HIV co-infection is like a double barrel challenge because each of these diseases have their own serious public health issues. So to be infected with both is a serious case. But the treatment for HIV, everything for HIV, we know that there are regimens that government has provided. It's for the individuals that are affected, early detection and treatment. So the ART centers are still open. There is one at the General Hospital, it's still functioning because I know somebody who is getting drugs from there and is following up. TB also, TB is curable, unlike HIV, which is not curable. But the key lies in compliance in taking the anti-TB drugs.
Right, thank you very much.
Thank you.
Thank you very much. Please, let's appreciate our presenter.
Thank you so much. We are going to the next presenter. Remember, his presentation is 5 minutes. 4 minutes will warn you. And then the last minute, please go to your conclusion. We call on Ikemini. Jeremiah, please take the stage.
Okay. Good afternoon, Prof. Good afternoon, doctors and fellow lecturers in the house and my colleagues. My name is Ekemini Jeremiah Okbong. I stand in to present on behalf of my colleagues in the team with the topic assessment of fetal heart rate and epicardial fat thickness in relation to estimated fetal weight and maternal characteristics in second and third trimester pregnancies. Okay, my content is there. Now, we all know that fetal heart rate is an important metric for evaluating well-being and development. But when there are abnormal values of fetal heart rate, there is a high suspicion for impending or underlying compromise. Maternal characteristics like weight and age are critical factors contributing to adverse pregnancy outcome. However, their relationship with fetal heart rate and epicardial fat thickness in pregnancy remains poorly understood. Now, in addition to the impact of epicardial fat thickness on fetal heart rate and estimated fetal rate, this has not been explored enough. This study aims to investigate the relationships between maternal characteristics, which is the weight and age, in relation to fetal parameters of fetal heart rate and epicardial fat thickness. What is epicardial fat thickness? This has to do with the space between the outer layer of the myocardium and the inner layer of the pericardium. Now, this can be gotten as a landmark through the annulus of the aorta. We look at the objectives. What do we stand to gain after doing this study? It is done to investigate the relationship between epicardial fat thickness and fetal heart rate. To investigate the relationship between epicardial fat thickness and estimated fetal weight. Scope. The study focused on pregnancy during second and third trimesters to extract data. This study was conducted in Every Care Medical Center in Ikotekpene and covered a period of 11 months. Now, the materials. A standard Siemens ultrasound machine with color Doppler was used with the serial number, the software, and the computer with capture materials were used. A prospective cohort design was employed in the study, and study included about 210 mothers in their second and third trimesters. And only pregnancies in second and third trimesters were included in this study, and apparently healthy pregnancies as well. Pregnancies with fetal anomaly and maternal conditions were excluded as our exclusion criteria. First trimester and multiple pregnancies were also not included in the study. Now, please, next slide, please. We want to talk, next slide. Okay, so when we talk about fetal epicardial fat thickness, we understand that it is something that has to do with anatomy, and we are able to now see the fetal heart and measure the epicardial fat thickness on scan. Results. We have seen that there is a strong clustered point with significant strong relationship when it comes to fetal epicardial fat thickness and it amounts to about 21.6%. Okay, now, so in summary, this study demonstrated a significant moderate negative relationship between the fat thickness and fetal heart rate. A moderate negative correlation exists between epicardial fat thickness and fetal estimated weight. But most significantly, this study developed a model for the prediction of epicardial fat thickness with fetal epicardial fat thickness and that of the fetal weight as independent predictors. Now, the results provided a number of statistical significant association. One of the most striking findings was the apparent strength of fetal epicardial fat thickness as a predictor of both estimated fetal weight and heart rate. Future studies as recommendations may benefit from adopting longitudinal designs which will help classify causal relationships. Additionally, standardized training for sonographers would increase and improve measurement viability. Thank you.
Thank you very much, the presenter. Do you have any concern, any question from the audience? Right, let's take a few concerns here.
All right, my concern is on ethical approval. Did you obtain, because while you were presenting, I did not hear you say you obtained ethical approval.
Okay. Thank you so much, Doc. Ethical approval was gotten from Ministry of Health, Akwa Ibom State. Was gotten from Department of Radiography, University of Calabar, and was gotten from Everycare Medical Center, Ikorekwene.
Did you get the consent of those patients?
Yes, consent was gotten because we actually measured their weight and their height to get BMI, so consent was gotten.
The consent I'm talking about, consent for this research to be used for this. Did you seek for their consent that for the information? Because when you come to a hospital, definitely these are routine checks. Maybe you may have extracted that information from their medical record. Or did you tell them that you are going to use this information for this study?
Okay. Each patient that presented for a routine antenatal scans were briefed of the need for this study, and they willingly gave consent to it. So those data were gotten based on their consent.
Yes, you know why I'm asking you this? Oral consent is not enough. You should prepare a consent form. I think when I was teaching research, I think that was what we were. You should prepare a consent form to be signed by each of them because of litigation. You should prepare this type of study. You prepare a consent form and you give to the, after explaining, the person signs. I don't know whether you did that.
Okay. Thank you so much, sir. Forms, we had the forms prepared, and each patient signed off on it.
Thank you very much.
Thank you so much, sir.
So consent forms depends on the nature of the research. All right. So let's appreciate the presenter.
Thank you, Ekemini. Please, we are going to the next presenter. Yolo BS, please come on. Omar, see you should prepare, please.
Good afternoon, session chair, professors, lecturers, attendees. My name is Yolo Bakmo-Smith. I'll be presenting on behalf of my team the prevalence and patterns of cardiovascular risk factors among healthcare workers in Calabar Metropolis. This work is highly relevant to this conference theme, mental health and economic productivity, because a healthy workforce is a productive one. Next slide, please. Introduction. Okay, so these are the outline here, introduction. So by definition, cardiovascular risk factors are characteristics that predisposes one to a cardiovascular event. Example, stroke. And these are divided into modifiable and non-modifiable risk factors. So for the modifiable, we have obesity, smoking, alcohol. The non-modifiable is the age, gender, and of course genetic predisposition to this event. So sadly, globally, these risk factors are increasing and drastically in sub-Saharan Africa due to the low resource setting. And healthcare workers, surprisingly, who are the heart of this, for the care of this, are showing high prevalence, largely because of occupational stress, night shift, and poor sleep. In Nigeria, we see this trend too, with poor diet and sedentary lifestyle problem. Okay. So the problem is very clear. There is a rising prevalence of risk factors like hypertension, obesity in our workforce. And there is sparsity of data in this regard due to, and also there's a limited access to workplace screening, especially in our setting. So ignoring this trend will lead to an overburdened workforce and healthcare system. So our goal was to quantify this risk and identify those gaps. So for the aims and objectives, the aim was to assess the prevalence and patterns of cardiovascular risk factors in Calabar healthcare workers across all the 3 tiers of healthcare. And objectives were centered to determine the prevalence of cardiovascular risk factors like hypertension, diabetes, identify the major problems, and find the gaps in workplace screening policy. So materials and methods. We conducted this study using a descriptive cross-sectional study across the 3 tiers of healthcare, primary, secondary, tertiary. We used a sample size of 359 using the Cochrane formula, and we recruited them using multi-stage sampling technique from facility all the way down to their units. Data was collected using self-administered questionnaires. We did anthropometry measurements like BMI, we did blood pressure, we did waist and hip ratio, and also used a standardized chart, the WHO International Standard Society of Hypertension Ratio Risk Prediction Chart. And we analyzed our data using SPSS version 26. Descriptive was done frequency and percentage using for categorical data, frequency and percentage. Then by valid, we used chi-square test of independence and Fisher's exact at p-value of 0.05. And we did multi-valid analysis using logistic regression. Got our approval from the Calabar University Teaching Hospital Health Research Ethics Committee. So for the results, prevalence of hypertension was at 23.4%. And those that were previously diagnosed of hypertension, over half, that's about 55.3, still have high blood pressure at the time of this study. So this tells us of a major problem, which is the problem of control. We also found out that advanced age, lower education, and next slide, please. Lower education and non-clinical roles like health assistants carried the highest risk. Non-clinical staff had more double the risk. For diabetes, 2.5% were diabetic. And the pattern of risk factors, the most prevalent was physical inactivity and followed by poor diet. So in discussion, this prevalence of hypertension, though lower than the national average, shows that there is need for intervention. And for the patterns, using the WHO charts, we show that this low prevalence is quite due to the younger demographic, but there's need for implementation. So we recommend to the directors of health facilities, CMDs, to implement clear annual screening policies, as policies are shown using the odd ratio of 6, show that once there is a policy, there is the ability to implement will be higher. So the lack of policy is a major problem. So the state's ministries of health We need to subsidize screening costs for staff, and federal policymakers must make cardiovascular screening mandatory for all health workers. So in conclusion, we have found a high burden of multiple modifiable risk factors like poor diet and inactivity. The lack of formal policy-driven screening programs is the major obstacle. The solution is integrating mandatory screening and lifestyle programs into occupational health. Without this, the rising risk will threaten both our workforce and the quality of care. Thank you.
Thank you very much, Mr. Yolo. So any question, any concern? Right, in the absence of any concern, let's appreciate Mr. Presenter. Thank you, well done. Congratulations.
Thank you, Mr. Yellow. I wish you would be green. Now we are calling Umar, see you, while Afion, Akande should get ready.
Good afternoon, my professors, the chairman of this occasion, my lecturers, and everyone here present. My name is Umar Christopher, and I am a final year medical student of the University of Calabar Teaching Hospital. So I'll be giving I'll be talking on the topic obesity and lifestyle behaviors among secondary school children in Calabar Metropolis, Cross River State, Nigeria. Now, this is the outline. I'll give the introduction. Okay, yeah, thank you. So, overweight and obesity among children and adolescents have become a major public health challenge globally, especially in low and middle income countries like Nigeria. In the local context, which is Calabar Metropolis, adolescents in Calabar are increasingly exposed to sedentary habits, high-calorie fast foods, sugary drinks, and reduced physical activity. And now, we all know that early onset obesity increases the risk for adulthood obesity. The study rationale, despite increasing concerns, there is limited recent data among the Calabar context. So this study provides updated evidence on BMI status and the lifestyle behaviors among these cliques. You get. So, like I said earlier on, the statement of this problem, childhood and adolescent overnutrition has become a major public health concern worldwide. And overnutrition during adolescence is particularly concerning because it tracks into adulthood, increasing long-term risks for hypertension, diabetes, cardiovascular disease, and a reduced quality of life. Why is this important? Families, schools, and the wider community are not fully equipped with the structure, awareness, or supportive environment needed to promote healthy lifestyle behaviors. Without evidence-based intervention and targeted preventive strategies, the pattern of unhealthy weight and behaviors is likely to worsen and strain individuals, families, and the health system. Now, what were my aims and objectives? The general objective was to assess obesity and lifestyle behaviors among secondary school children in Calabar. The specific objective was to assess the prevalence of overweight The second one was to assess the prevalence of obesity. The third one was to assess the modifiable risk factors among secondary school children in Calabar Metropolis. And the last was to assess the factors which are associated with this problem. The materials and methods. The study design, it was a descriptive constitutional design conducted in Calabar Metropolis. The sample size was 263, determined using the Cochrane's formula. The data collection was data was collected using a semi-structured self-administered questionnaire, and anthropometric measurements were taken using standardized procedures. We used the weighing scale, stadiometer, and WHO BMI charts. The eligibility criteria is listed there, and ethical approval was obtained from the University of Calabar Teaching Hospital Health Research Ethics Committee. Informed consent, confidentiality was ensured using serial numbers and secure storage of data. Now, for our results, the overall mean age was 13.13, plus with a standard deviation of 1.75 years. Majority of them fall within the age bracket of 13 to 20. The sex people, for their gender, females were about 46.4%, while male was 53.6%. Now, for our results proper, the majority of students, for the prevalence of obesity and overweight, the majority of students had a normal BMI, that was 58.2%, while 13.7 were obese and 9.5 were overweight, while the others were underweight. Modifiable risk factors you can see here, the most important ones are the high fast food consumption, availability of sugary drinks at home, high sugary drink consumption, prolonged screen time, and physical inactivity. Now, for the factors associated with obesity, there were actually no statistically significant association from the social demographic factors and the anthropometric measurements we got. So, for our discussion, there's a combined prevalence in this study was 23.2%. Nearly 1 in 4 students were above a healthy weight, which is alarming. In summary, the study assessed overweight and obesity among 263 secondary school students in Calabar Metropolis. Our prevalence of overweight and obesity, like I said, was 23.2%. Overweight, in conclusion, overweight and obesity is a major public health issue in Calabar schools. Both underweight and overweight/obesity show a dual burden of malnutrition. Interventions should be broad-based, focusing on modifiable risk factors. For my recommendations, the government and policymakers, there should be public health campaigns that promote healthy school environments and integrate nutrition education in school. They should also encourage sport and physical activities, offering counseling, educating parents on healthy habits. And finally, they should provide balanced diets, limit fast food and sugary drinks consumption among this population. Thank you very much.
Thank you very much. Thank you very much. The presenter. Any concern? Any question? Right, in the absence of any question, let's appreciate him for the good presentation.
Thank you very much.
Thank you. We're calling the next presenter, Afion Akpandem, while Oyeniyi TI should get ready.
Good afternoon, the chairman, other lecturers, and my audience. My name is Afion Akpandem. My topic is evidence-based practice in radiography, the awareness, institutional barriers, and implementation strategies in the healthcare system in Nigeria. I'm a PG student in radiography and radiological sciences department, University of Calabar. My outline is there. The introduction. The practice of radiography is an essential aspect of in health system. It's found through the diagnosis and hello. Please bring out of your pandem evidence base. Check a community work now, you might be there. As I said earlier, the practice of radiography is an essential component of medical diagnosis, playing a central role in patient care and also staff welfare, according to Cho in ATEL in 2025. In Calabar, as my major center for my studies, radiography department serves as a pivotal point of imaging processes where imaging operations are being carried out for patients. And there are several modalities. There is X-ray, there is computed tomography, the CT scan, the MRI, that is the magnetic resonance imaging scan, ultrasound, etc. Statement of problem. Without the adherence to EBP, patients may receive inappropriate imaging tests, which can interfere in their treatment. EBPM implementation requires effort from both the institutional, that is authorities, and also the practicing radiographers, which has to take care of the patient. If this is poorly equipped or the professionals is under knowledge, the patient might be affected in terms of treatment. The aim of this study was to assess the evidence-based practice among radiographers in Calabar. Objective of the studies. There are about 5 objectives. The first one was to estimate the awareness, to check the awareness, the familiarity, understanding of radiographers practicing in Calabar, in Nigerian hospital in Calabar precisely, to investigate the association between gender and the level of knowledge of radiographers, and also to describe the challenges each radiographers face during the practice of this, during the processes of attending to patients, and also to promote the effective integration of EBP, that is evidence-based practice in Nigeria. Significance that this study will help to give a contribution to the growing discourse of medical imaging in Nigeria and also in research. Materials and methods. Materials we used was self-administered questionnaires, both Google and hard copy, where it was distributed to radiographers at different hospitals. Public and private hospitals was mostly used. Study design was a descriptive, and inclusion criteria was licensed radiographers practicing in Calabar only. Sample size was 83 respondents, and exclusive criteria were radiography students under clinical posting, and radiographers, non-radiographers, and also individuals that were not interested at the time of the examination. The result was used to compare the awareness, understanding, and also to check the challenges each radiographers faced. And in summary of the findings, it was discovered that there was consistently poor level of familiarity, even awareness and understanding of EBPM among radiographers practicing in Calabar in these hospitals. And also it shows an insignificant association between gender and familiarities, with a chi-square of 9 and a p-value that it was less than 0.1. The results revealed that no statistical association was there to compare between the radiographers and also radiographers practicing in terms of the early stage and that is between 1 year to 5 years, and radiographers have practiced for long. Institutional policy was considered also, and it shows that most suggestion comes from there because institution has a ranking where the authorities has a major role to play in implementing EPM. Discussion. From the study of these 83 radiographers that were used, institutional policy was considered the most in terms of suggestion of promoting EBP. And while regular EBPM workshops, training and retraining, and access to database, research materials also was seen to be higher because of the non-encouragement of these workers. Contribution to knowledge. For these gaps to be filled, journal and access to research materials and databases should be encouraged, and also retraining programs should be done in order to promote evidence-based practices in Calabar hospitals. Thank you.
All right, thank you very much. Thank you very much for your presentation. Do we have any concern, any question for her? Right, it's like there is no concern. So congratulations for the presentation. Let's appreciate her as she goes down for the next person to come up.
Thank you. While Chidibere should be ready.
Good afternoon, my professors. Good afternoon, my lecturers, my doctors, and my fellow colleagues. I'm Chibike Mosakwe, a final year medical student from the Department of Community Medicine. I'm here to present on the topic titled Compliance with Road Safety Measures are more commercial drivers in Calabar Metropolis, Cross River State. Here is my outline, introduction, statement of problems. Okay, for the introduction, compliance to road safety refers to the act of obedience to rules guiding the usage of roads by drivers and road users. Between 2020 and 2023, the South region experienced a 2.5% injury-related cases and 17.5% death-related cases. Similar study in other parts of the country showed 74.6% compliance in Kwara State, 63.7% compliance in Delta State. Statement of problem: road traffic accidents. Road traffic accidents are a leading cause of death yearly, with 90% of occurrences in underdeveloped countries. There is an inadequate assessment of the causes of road traffic accidents in Nigeria. Despite continual efforts to mitigate road traffic accidents by enabling compliance to road safety measures, there is a paucity of research on this issue. Hence, a need as this study to aid in the development of effective, timely intervention to improve road safety and reduce the incidence of road traffic accidents and fatalities. General objectives to assess the compliance of commercial drivers in Calabar to road safety measures, and for the specific objectives to assess knowledge of road safety measures among commercial drivers in Calabar, to assess the attitude to road safety measures among commercial drivers in Calabar, to identify the level of compliance among commercial drivers in Calabar, and to identify the factors associated with the compliance of commercial drivers to road safety measures in Calabar. Materials and methods. The study was done in Calabar Metropolis, to be precise, Calabar South and Calabar Municipality. Study design was a descriptive cross-sectional study, and sample population was done. Study population was commercial bus drivers in the Calabar Metropolis. Sample size was 245. Sample size was 245, which was determined by using the Cochrane's formula. Sampling technique was the multi-stage sampling technique, and eligibility criteria, we had both inclusion and exclusion. For the inclusion criteria, drivers who had more than 1 year driving experience and drivers who gave consent to partake in the study. Then for the exclusion criteria, drivers who were not present in the park at the time of the study, and then we used a pre-tested, modified, self-administered questionnaire with questions adapted from drivers' compliance on road traffic rules and regulations questionnaire. Data analysis was done by using the IBM SPSS version 26.0. Ethical consideration was taken from UCTH Health Research Ethics and Committee. Okay, from the study we did so far, we had about 245 participants in our study, and so far, more than half of them demonstrated good knowledge, which was 66.5%, attitude of 62.8%, compliance of 62.8% to road safety measures. Factors associated with road safety measure compliance included marital status, average monthly income, and amount of time spent on driving per week. Here's a pie chart showing the level of compliance, and then the table, bivariate analysis table to show you what factors affected compliance. Now, for the discussion of the results, the study reviewed approximately 62.8% of commercial drivers demonstrated good overall compliance. This was generally as a result overall compliance with road safety measures, while over 1/3, that is 7.2, showed poor compliance. Compliance was generally higher for safety behaviors that are easily monitored or visibly enforced, such as use of seat belts, traffic signaling, use of mirrors, side mirrors, obeying traffic lights, or avoiding alcohol or smoking while driving, and having the required safety equipment. In contrast, lower compliance was noted for behaviors such as consistent traffic light obedience, mobile phone use while driving, and seatbelt use in certain circumstances, suggesting that drivers are less likely to adhere to rules that are not consistently enforced or are difficult to monitor. Following the study, we had some implications. So the implications we had from here was that From here, we had that some agencies that, such as the FRC, the CTRA, that's the Cross River State Commercial Transport Agency, would use our study to mitigate LTAs on some specific domains of compliance. In conclusion, although quite a number of commercial drivers in Calabar Metropolis demonstrated good knowledge, attitude, and compliance to road safety measures, a handful of them still remain non-compliant. Hence, continuous education, sensitization on road safety measures with focus on balancing the time spent on the road is still needed to achieve an optimal level of compliance. Thank you.
Thank you very much. Is there any question? Is there any concern? Right, the only immediate concern is that your preparation was not on PowerPoint. Your presentation is not PowerPoint. What you presented, I was seeing notes points, not PowerPoint. Believe you know the difference between PowerPoint and note points during presentation. Right, if we have time, we'll talk on that. So on the whole, in the absence of any other concern, let's appreciate the presenter. The next presenter, again, are you the one presenting?
You are coming for Chidibere. Okay. Chidibere.
Sorry. Those that are working out, somebody sit down and listen to you. So you should listen to other presenters. If it was like that, it means you would have presented last and present empty seats. Right?
Thank you, Chair. Please, we are calling on Idaka Basi, OE. Now, in the absence of that presenter, we call on Josephine E. Egbun. Please take the stage. While Agbola Rutimi to get ready.
Good evening, my distinguished professors, lecturers, students, and participants. My name is Josephine Egbun. I am presenting the title of my presentation is Caregivers' Nutritional Knowledge, Child Feeding Practices, and Nutritional Status of their under 5 children in Akpaboyo local government area of Cross River State, Nigeria. The background of the study. Nutritional status during childhood is fundamental determinant of health because it influences the growth, development, and overall well-being of under 5 children. Statement of the problem. Understanding a caregiver's role in under 5 children is vital for knowing the kind of intervention to bring up. And also, there is paucity of data on caregivers' nutritional knowledge on under 5 children in Akpaboyo local government area. The aim of this study was to investigate the nutritional knowledge and feeding patterns of caregivers and their effect on the nutritional status of under 5 children in the study location. The specific objective of this study were to assess the level of nutritional knowledge among caregivers of under 5 children in Akpabio local government, to examine the feeding pattern of caregivers and the adherence to the recommended feeding pattern, the feeding guideline of the under 5 children, and also to evaluate the nutritional status of under 5 children using anthropometric methods. And the last specific objective was to determine the relationship between nutritional knowledge of caregivers and the nutritional status of their under 5 children. The methodology, the study location that was chosen for this research was Akpabio local government area, and the study design that was used was cross-sectional descriptive design, and the study population were caregivers under 5 child pair, and the sample size was calculated using Cochrane's formula with 5% non-response rate, and this gave us 404 caregiver child pairs to work with. And the sampling procedure used for this study was multi-stage sampling, and that's what was used to select the respondents. The data collection tool that was used was Kobo Collect was used, and interviewer-administered semi-structured questionnaire was also used based on the study objectives, and anthropometric measurements such as height, weight, middle palm circumference was also taken following the standard procedure. And the data analysis was carried out using SPSS version 25, and the descriptive and inferential analysis was also carried out. And the result shows that most caregivers had a fair nutritional knowledge level, and this was assessed using the mean scores from the survey response. And regarding the feeding practice level of the caregivers, 57.2% had poor adherence to feeding practice, and only 42.8% had good adherence to the recommended feeding practice. The nutritional status of the under 5 children from the slide shows that a lot of the under 5 children had good nutritional status. The association between the nutritional knowledge of caregivers and the nutritional status of the under 5 children was tested using the chi-square statistic, and the p-value was was less than 0.05, and the results showed that there was a statistically significant association between the nutritional knowledge of the caregivers and the nutritional status of the children, especially for the BMI for age. Discussion. The study findings revealed that majority of respondents had fair nutritional knowledge, and this pattern aligns with previous studies. And also, the study shows that a significant proportion of respondents adhered to the recommended feeding guidelines, and other studies too confirmed that. With regards to the nutritional knowledge, the association between the nutritional knowledge and the nutritional status of the under 5 children. So the result shows that there is a relationship. So in conclusion, most caregivers in Akpabio local government possessed fair nutritional knowledge, and they adhered to the appropriate feeding practices. Sorry. In conclusion, most caregivers in Akpaboyo local government possessed fair nutritional knowledge, but their adherence to the appropriate feeding practice was poor, and which significantly impacted the nutritional status of their under 5 children. The references are as follows. Thank you.
Thank you very much. Thank you very much. Any concern? Any question? Right, in the absence of any question, let's appreciate Dr. Ebum.
Thank you. The presenter, please call on Agbola Rutimi. Your time counts now.
Hello. Good evening, my esteemed professors, my senior colleagues. My name is Abdulakim Rotimi Agbola, a lecturer in the Department of Biochemistry, Faculty of Basic Medical Science, and I'm here to present this project, which is titled Theobroma cacao seed extracts attenuate dyslipidemia and oxidative stress in L-name-induced hypertension Wistar rats. Okay, this is my, okay, next slide. So this is my content. Now, to the introduction, hypertension is actually known as a chronic medical condition which is characterized by persistently elevated blood pressure. Then we talked about the dyslipidemia refers to abnormal levels, that's dysregulation in the levels of lipids in the blood, which is usually characterized by low level of HDL, high level of cholesterol, TG, and LDL. Then inflammation and oxidative stress. Oxidative stress is actually a condition characterized when the reactive oxygen species overwhelm the body's ability or the body's antioxidant capacity. So it results in a condition known as oxidative stress, which is a precursor to many metabolic diseases, including diabetes, hypertension, cancer, and so on. Antioxidants are molecules or substances that counteract the effect of oxidative stress. They help to scavenge these reactive oxygen species, thereby returning the balance of the body to its normal state. Talking about cocoa, so our intervention molecule here, or the compound we are using, or let me say the substance we are using here is cocoa, known as the Theobroma cacao. Cocoa is actually a popular plant, which is most used in production of beverages. And so that's cocoa. Anyway, you can go to the next slide, please. So my statement of problem. Now, the growing prevalence of hypertension and diabetes and other chronic diseases is actually a source of concern to researchers worldwide, most especially that the medications, the orthodox medications that are used in the treatment of these diseases actually come with their own side effects. And apart from that, the cost, looking at the exchange rate, especially for low and medium income countries, the cost to acquire these drugs is actually prohibitive to most of the sufferers of these diseases. So it makes these drugs out of reach for most people living in these countries. The aim of this study is determination of the antihypertensive effect of tea cacao extract, while the main objectives are to determine the in vitro antioxidant effect of tea cacao extract, that's ethanol and chloroform extract in hypertensive rats, to also determine the in vitro anti-inflammatory effect of tea cacao in hypertensive rats, to determine the in vivo effect of tea cacao on lipid profile, that's look at its effect on dyslipidemia, then finally to characterize tea cacao for the identification of the active phytoconstituent. Next slide, please. Now the materials and method. The method followed standard procedures as seen in literature. Please, next slide. Now to the result. The results we actually considered in the in vitro analysis, we considered nitric oxide. Nitric oxide is actually a vasodilator, so which is produced naturally by the body, endogenously by the body. It's produced from amino acid arginine, methionine, and glycine. And so we looked at the ability of this particular extract. What if they could induce, or if they could induce the production, or sorry, their effect to inhibit nitric oxide, because the overproduction of nitric oxide is actually known to, nitric oxide. So we look at ethanol, chloroform, and ascorbic acid is the standard there. So the result shows, okay, let me use my own here, sorry. I can't see what's there very well, it's far from me. Yes, I'll use my laptop. Okay, so the ethanol extract is coded in blue, chloroform in pink, white, the ascorbic acid in that colorless color. Let me put it that way. So we can see that from this, the ethanol extract has the best activity when compared to the chloroform and even the standard drug, the ascorbic acid. So it was able to inhibit the overproduction of nitric oxide. Then looking at the DBPH in vitro activity, we noticed that the ethanol extract also outperformed the chloroform extract, although it actually, both of them did not do as well, did not do much compared to the standard drug, and that is the same thing that happened for other parameters, including the ABTS and the hydrogen peroxide. So you can see that that trend was consistent, and the response was actually dose dependent. As the doses were increased, the activities also were increased. Next slide, please. Now, looking at the lipid profile, this is the one that we looked at the effects on. No, sorry, I think you jumped the slide before then. Looking at the next slide, we're looking at the effect on inflammatory markers. We look at the in vitro effect on protein denaturation and it-induced hemolysis and proteinase inhibition. We saw that the pattern followed the same in that our ethanol outperformed the chloroform extract, but both of them were less potent than the diclofenac, which served as the standard drug. Now for the lipid profile result, now if you look, we actually took a baseline systolic and diastolic blood pressure at the beginning of the study to establish a baseline. Now, at the day 14, we actually started treatment after that. Then, from day 14 and day 21, we observed the changes in their systolic and diastolic values. Now, looking at the group 1, which is our normal group, if you look at the baseline, reading 74 for the first one here for total cholesterol. Now, at day 14, it actually increased, but at day 21, our extract was, of course, it's actually normalized. Now, looking at the group 2, which is the untreated, we noticed a pattern where there was continuous increase because there was it was just, we just administered distilled water, we didn't give them any treatment. So there was continuous increase in the blood pressure even till day 21. But for others, we could see that at day 21, there was reduction from group 3 to group 6, group 3, 4, 5 at the ethanol extract, 6, 7, 8 at the chloroform extract, and we saw that both of them actually were able to reduce the blood pressure, while for group 9 is our standard drug, which of course some of our extracts even outperform them at day 21. Then looking at the triglyceride, it followed the same pattern. Our group 2 continuously increased, 91 at the baseline, 139 at day 14, and 156 at day 21, showing that is a negative group. We didn't administer any treatment. But if you look at other groups, you will see that there was actually reduction at day 21, showing the effectiveness of our extract on this hypertensive rat. Now, this is the chromatogram for the HPLC characterization of our ethanol and chloroform extract. The HPLC chromatogram shows that quercetin actually had a very high peak Then we see from here, then if you look at the next slide, we saw that the ethanol extract performed as we had more phytoconstituent than we had in the chloroform extract. Now to conclude, we have shown in this study that the in vitro antioxidant activity of ethanol extract of tea cacao was higher than the chloroform extract, probably due to the richness in phenols and flavonoids. Of course, several studies have been able to confirm that cocoa extracts are actually rich in these two phytoconstituents, the phenol and flavonoid. And because phenolics are actually polar substances, so it is expected that most of them would actually go into the ethanol solvent more than they would go in the chloroform solvent. So that would explain the reason why we have a better effectiveness of the ethanol extract compared to the chloroform extract. Then finally, our conclusion is that the ethanol extract performed better than the chloroform extract at all concentration and was able to restore the lipid balance after 28 days. The implication, okay, I think this is the conclusion. Anyway, so that was my discussion, but I think I've merged both the discussion and conclusion together. Thank you very much for listening to me. God bless you.
Thank you very much. Is there any concern, any question? Okay, yes, there's a hand here. Please, who is that person that has disappeared? Please, the mic.
Now, these solvents which you use in extract, is it compatible with man? Because I'm thinking that this work is in the animal model, then can be transported, am I correct, to human beings, isn't it? Can we use the chloroform to extract the component for man? That's one. And then secondly, the effect that we are having, is it really out of the component, that's the contents of the cocoa, whatever you use, or is it the effect of the ethanol itself that is reacting or giving you the result you have?
Okay, thank you very much. For the ethanol, ethanol is actually a volatile substance, and after our extraction, of course, we make sure to recover the ethanol that was used for. So what we have, after the extraction, we had to undergo drying to make sure that most of the ethanol were actually, how would I put it? Of course, it's a volatile compound.
Evaporated.
It's evaporated. So that's one. Now for the chloroform, yeah, truly chloroform is not compatible with, because it has its own toxicity. However, similarly, we had to, one of the process we did after extraction was to make sure that these samples were dried to be able to make sure that the solvents were not really part of what we are going to be administering to the rat models. That's for, then for the second question, if the, of course, I think it actually basically answers the question too. Because our ethanol, we make sure that they were evaporated, so they were not actually, so our effect was due to the phytoconstituents in the cocoa rather than what we used to extract. And to actually validate that further, we are actually going into in silico studies, because we have done the characterization of our cocoa to determine which of the constituent itself actually has this effect. And that's the next phase of the study, ma'am. Thank you so much.
All right, thank you very much. Sorry. Were you using normal animals?
No, they were induced with L-name. Okay. That's the nitroarginine methyl esters. L-name. They were induced with L-name to induce the hypertension.
It's all right. Then, why didn't you try aqueous extracts?
To try what?
Aqueous extracts. Aqueous.
Okay, aqueous extract. Okay. Okay, that's okay. To replicate what happens in the, okay, I think that's a very That's a good suggestion. Well, of course, we learn. I think I will take that as one of the takeaway from this. Exactly. Thank you so much, my
I've
prof.
tried that because the chloroform is, despite the fact that we try as much as possible to recover the active ingredients, we cannot rule out the fact that there is still some elements of the solvents. Right, thank you very much for the presentation. We are almost finished, but just exercise patience. There is one person that is going to take a virtual. The person sets ready. If it's not ready, we can present tomorrow morning. I don't know what program for tomorrow morning. All right. Thank you very much for the patience. I want to appreciate. Were you supposed to present? Well, you didn't show any indication that you are presenting. Should we still take her? Huh? You are presenting? Who among you is ready? Please, I requested that we should not go. Those that are outside, can you come in? We are rounding off. Just come and encourage those that are presenting. We may reduce the time now. So you have to fly like a jet. Sorry, were you supposed to present in this group or you missed your slots? Yeah, you have the floor first.
Good evening, my honorable panel, distinguished ladies and gentlemen. My name is Achibong Agnes Edo, and I'll be presenting on the topic, nutritional evaluation of 2 indigenous complementary foods commonly used in southern Nigeria. Here are my content and introduction. Breast milk remains the ideal food for infants, providing essential polyunsaturated fatty acids, proteins, bioactive compounds, and readily absorbable minerals needed for optimal physical and mental development. However, after 6 months, breast milk alone cannot meet an infant's increasing nutritional needs. Complementary feeding beginning at 6 months and continuing to 24 months is therefore essential. Next slide, please. These are my statements of problem. Malnutrition continues to affect many young children in Nigeria due to poor complementary feeding practices, especially in rural low-income communities where families cannot afford commercial fortified infant foods. And then they are frequently fed with single cereal pap, a low protein and low energy density complementary food that is not nutritionally sufficient. That is nutritionally insufficient. Next slide, please. Aims and objective. The aim of this study was to evaluate the nutritional composition of 2 indigenous complementary foods made from selected locally and readily available stable foodstuffs. My objectives are determination of mineral composition, proximate composition, vitamins, and anti-nutrient content of the stable foods. Materials, the equipment used for these studies are as stated, and the reagents were all analytical.